Kiriti sir, President NNF Tirupati. I welcome Dr. Ramprasad Sisla sir, Secretary NNF AP State. I welcome Dr. Tejo Pratap sir, neonatologist from Fernandez Hospital. And I welcome Dr. Nori sir, neonatologist from Vijayawada. And I welcome Dr. Girdhar sir, Chief Neonatologist from Chettinad Medical College from Chennai. I welcome Dr. Murlidhar sir from Thrissur. I welcome Dr. Rajgopal sir, Chairman DigiNNF Committee. And hereby we are launching the CME program. So program will be included with 4 panel discussions. So first is on essential newborn care, then on NRP and management of birth asphyxia, and then less is more, management of respiratory distress in preterm neonate, and then we will be launching the clinics to clicks like heralding a digital transformation in neonatal care. This will be mainly emphasizing on our DigiNNF platform, and then we will be having 2 launches, that is all about sepsis and DigiNNF launch. Thank you everyone. Now I welcome Dr. Girdhar sir to welcome the panelists for the first session.
Good morning to you all. So it gives me immense pleasure to introduce the moderator and the panelists for the first session. The introduction of panelists will be done by the moderator. The moderator is Dr. Murli Raj, and he will be moderating the session on essential newborn care, which is unraveling the role of neonatal nurses. Even though it's going to be on the neonatal nurses who are going to be part of this panel discussion, I think there will be a mixture of everyone, the nursing staff, the obstetrician, and the neonatologist will be unraveling the role of neonatal nurses in this panel discussion. Over to Dr. Murli Raj, sir.
Yeah, I'll give it. So, a very good morning to all and greetings from Kerala. It's very happy to see a lot of delegates in the morning hours itself. And I do understand that more than 50% of these delegates are nursing students and staff nurses. It should be a lot for me or unfair for me if I stress the importance of nurses, because we all know that what is the management in NICU or level 3, level 2, level 4, whatever you grade, the majority of that monitoring, identification of the sick newborns, even the initial management before you call the consultant or the SRs will be done by the nurses. Without the nurses, we cannot even think of running an NICU, because we will not be able to do all those works in those NICUs, monitoring all those babies, even feeding the babies, changing their diaper, giving the injections, all those things. So in the next 40 or 45 minutes, we will be dealing with the role of these nurses in management of newborn. We will be starting from the labor room, delivery room, and also up to the discharge and counseling of babies who are admitted in the NICU as well as in the postnatal ward. So it will be an interactive discussion. In the next 45 minutes, what I am planning is not a hi-fi or rocket science. I have 4 panelists. We'll have some fun. We'll have some exchange of ideas. I will contribute mine and they will contribute their own. So we have 4 panelists with me. Dr. Karthikeyan. I would like to welcome Dr. Karthikeyan and Dr. Shashikar Reddy. Dr. at Siddhartha Medical College. Not working. And Dr. Karthikeyan is also a member of a lot of professional associations, IAP, IMA, and also this is chapter of IAP. And also he's a life member of intensive care chapter of IAP. And we have Mrs. Bengaluru Harsha Sri, is a neonatal staff nurse from Angura Hospital, Tirupati. Madam is also very well versed in managing this staff nurse, managing a level 3 NICU. Okay, sorry. Yeah. Oh, not going back. So as I told earlier, we'll have some exchange of ideas. So I would like to start from the delivery room itself, because we know that the care of the newborn starts from the delivery, whether it's a preterm or a term baby. It actually starts from the conception itself. But what we can do, what as a pediatrician, what we can intervene is probably from the late peripartum area or in the labor room. So I'd like to know from Dr. Karthikeyan. So Dr. Karthikeyan, we have a lot of nurses. We employ them in labor room, post-op delivery room, NICUs. So what do you think is the sole role of a neonatal nurse in the NICU? Because the nurse, not the NICU, not the labor room. So if a particular nurse is posted in the labor room, she will be handling the newborns only. So do you think such a concept will work? So what is your take on that?
Yeah, first of all, good morning, everyone. The neonatal services is a teamwork. It's not a single man show. So it doesn't mean a single neonatologist or a single pediatrician or single nurse can handle. So it's a teamwork basically. And now this is the era of perinatal medicine. So the role of nurse starts from antenatal care itself. So the nurse has to take part in counseling, in making the mother prepared for breastfeeding and the healthy practices during delivery, after delivery. So the role of nurse starts from that point itself. And during deliver, the how best the nurse could make the mother comfortable during the process of that a painful situation, because delivery is a very painful one. So definitely,
So my question was, some of the private hospitals, they'll be having a shortage of staff nurses. So they'll be distributing them to all areas. So it will be possible, it's practical if we ask them. So okay, you post a nurse in the delivery room who will take care of the newborns only.
in private hospital.
Yeah. The government hospital, okay, there'll be nursing students will be there, staff will be there. But in private hospital, so they will be assigning, one person will be taking care of the delivery, the mother, she will be assisting the LSES, she will be doing the neonatal resuscitation, she will be doing all the essential things.
Yes.
So that was my question. So any practical issues you face, you work in a private hospital, isn't it?
Yes.
So any practical issues you face in a dedicated neonatal nurse who cares only for the newborn in the labor room or delivery room.
So the first thing is like overburden to the ratio of delivery to the nurse is a overburden where the nurse quality or the quality of care is being faced. And the thing is they should be prepared for all the challenges, irrespective of even it's being a normal delivery or cesarean, whatever it might be. They should be prepared for all the challenges which are anticipate the challenges. And
yeah, that is the main thing. That is actually that making that delivery room in charge believe that the importance of a neonatal nurse, because who is trained in NRPs, or who is trained in identifying the sick newborn, and who is trained in giving at least a TPs. So who is trained in transporting the baby to the labor or to the NICU is very much important, so having a lot of importance. So my next question is to Ms. Harsha Sri. As a nursing officer, what are the important domains of patient care do you think you have to cater in the delivery room? Because you will be dealing with a lot of things, isn't it? As Dr. Karthikeyan has already told, you will be dealing with antenatal care, antenatal counseling, to delivery, to assisting LOCS, to shifting the baby to the NICU, everything. So what are the major, so as a person who is working in the NICU or level 3 NICU, what do you feel? What do you feel? What is your take on this?
Neonatal nurses played circular role in the delivery room, providing specialized care for newborns, especially those who are premature or sick or require additional support immediately after birth. Here, why their role is important. Immediate care for newborns after birth. Neonates for experience issues like difficulty breathing, low body temperature, or low blood sugar. Neonatal nurses are trained to quickly assess and address the issues, ensure the baby's vital functioning are stabilized. Monitoring and resuscitation. Neonatal nurses are skilled at resuscitation techniques such as a performing neonatal CRP. Clearly, always are providing oxygen if the baby is not breathing or it is distressed. The training is the areas can be life saving. Assessing the assessment. They assess the performing immediate assessments such as the Apgar score to evaluate the newborn's physical condition and identify the need for urgent medical intervention.
Yes. So what you are trying to tell is that from the delivery itself, uh, as Dr. Karthikeyan has already told, a dedicated neonatal nurse should be all equipped with receiving the baby and also identifying the sickness of the baby and also doing that essential initial management. Okay. Yes.
High risk deliveries for babies born prematurely with congenital diseases or high risk neonatal nurses work alongside doctors to manage the baby's condition, right away helping with tasks like monitoring vital signs or administering medications. Collaboration with the medical terms, neonatal nurses work closely with obstetrician, pediatrician, and other specialists in the in delivery room to ensure the health of both mother and baby. Their specialized knowledge of neonatal care is invaluable in making rapid decisions, prevent, preventing complications by closely monitoring the baby's right after birth. Neonatal nurse can help prevent complications like infections or jaundice from worsening by ensuring aseptic care and early intervention.
Yes.
If
So actually, the neonatal nurse actually offers a lot of pan support to the babies in the delivery room. And also, I like that your last point, that emotional support to the families, because that is what we doctors mainly miss. Okay, we will manage, we will do that scientific things, and we fail to communicate with the parents or all the families. Because I do have a lot of personal experience that the main communication between the family members and the the medical team is mainly done by the experienced staff nurse. So if something goes wrong from the staff nurse, so he or she will not be the primary respondent, we will be the primary respondent. So many times we do take help from them, and the experienced people are there to help us. So just want to emphasize the role of neonatal nurses in the labor room. So my next question is to Dr. Shashi, that we all train nurses, isn't it? We all train nurses. Actually, IAP, NRP, FGM is conducting BNRP, basic NRP, because which is somewhat a skewed training program that other than from that we do in advanced NRP. So do in the general programs in these NRPs, we train them up to this bag and mass ventilation, and we train them to do this bag and mass ventilation with the slow heart rate, vagus ventilation with the fast heart rate. Then after that, we just stop them and train them to how to call for help and how to shift. So do you think that is the only thing essential? So as I already told, that nurses are the paramount important persons in the management of babies, either in the labor room or in the NICU. So do you think we need to train them more, because the people from Central NNF are there? We are going to launch our platform. There are a lot of decision-making people are there. So as part of the NNF or in combination with IAP, do you think that we have to extend their training to some more else thing that includes the essential newborn care also?
Sir, actually, the thing is we can train, sir. The thing is only 1% needs the invasive things. In a periphery, maximum 10% only need resuscitation. If you concentrate more on basic NRP, who are well versed with the training, I think we don't have any further issues. Those who are interested, who wants to pursue further, in that we can train them, because only hardly 1% needs intubations and all advanced NRP. The rest other needs only basic NRP till bag and mask, when to start, how they are able to see the chest rise. That decreases the morbidity.
Yes, that's true. But my question is that is it only that NRP needed? So how, like, in Kerala, we used to give this comprehensive nursing management in the 3-4 years back under the IAP Kerala Business Action Plan, in which we used to train them about managing the common things also.
Yeah, we can, sir. Because the thing is, along with NRP, identification of danger signs.
Yes.
Because they'll be with the
That's what I meant.
close with the community.
Yes.
Like ANMs and ASHAs, if they see that what are the danger signs, they'll have a close communication with the mothers,
Yes.
so that they'll early pickup will be there, like a signs of sepsis or shuttle seizures. So
Yes.
they can be early referral also to
Yes,
the nearby center.
Yeah, even it's not a very dangerous thing. Identification of a neonatal jaundice, a significant jaundice, because many a times in the community level can be missed. Many a times in the postnatal ward can be missed. A busy pediatrician going, taking the rounds, seeing 10, 15 patients in 15 minutes. I think I used to miss, and my nurses used to pick. So that was the crux of my question. Rather than training them just to do a bag and mask ventilation or just to do an initial, I'm not telling that those things are not important, because they are the important things. Along with that, we can train them about this, how to identify the sick newborn, what are the basic things. If the baby comes to you with the seizures, what are the important things, important investigations as you have to take, or what are the immediate things you have to do for this, at least to give some oxygen or give some glucose, or just check that, at least check the glucose. That's the thing you can try, because in periphery level, majority of these things are lacking. Okay. So my next question is to Dr. Satish. So we already told that we are having a nursing support in the labor room and antenatal management of baby, these mothers. So counseling is an important part, because many times the bystanders comes, the caretakers comes and speaks with the nurses. After half an hour, they speak with us. There will be some conflict of interest. There will be some difference. There will be some indifference in the points. And these people are so smart, or at least the patients in my state are so smart, they will catch up the difference only. Okay. They'll catch up the difference only. So what do you think? What do you think that our counseling or this dealing these parents or dealing the bystanders together? That's a nurse-doctor combo.
So good morning all. Sir, nowadays counseling is a very important part of our day-to-day work for doctors, nurses, and for the entire team. So whoever is doing a good counseling is going to become a champion.
Yeah,
Definitely.
that's true. I think that should be the word of the day. whoever doing the good counseling is going to the champion.
Yes.
Not whoever is doing that good management, but
you have to do a good counseling. So whoever gives the time for counseling, they are going to do very well. So essentially, when we come to the role of nursing staff, it's been tested before as well. So in certain parts of the world, definitely the nurses take an enhanced role, come with the doctor, stay for the counseling as well, and learn the tips. So essentially, nurses, they have to think that they have an enhanced role between the doctors and the families. As you said, if there is any mistake or there is an information which has been lagging between them, that can be really given by the nurses as well. So for that, they have to have certain principles. Okay, not only doctors, the nurses should have the principles that they should understand what are the expectations from the family. That will start from the antenatal period itself. What will happen if there is a normal delivery? What would happen if there is cesarean section? So immediately, once the baby is taken from them after the delivery, they are all anxious. What's happening? Is my baby seriously ill, unwell? So all those things, they can be counseled that if baby is all well, this is what we will do. If the baby is unwell, the doctor will come and see, a pediatrician will see. Or if the baby is more unwell, the baby will go to ICU. So this type of at least a simple kind of counseling will definitely help the family that they are all giving the right information consistently. So they can tell that what will happen immediately after the delivery as well. By that, the expectations of the family will be met. So one other important part is apart from the counseling, along with the counseling is documentation and communication with other staff, their nursing home staff, that once they change the shift, they should be able to tell them what exactly happened. Because the principles of essential newborn care, the four things have to be kept in mind when they're doing this counsel is keeping the baby warm, delayed cord clamping, making sure skin to skin happen early, early initiation of breastfeeding. These are all going to reduce the mortality. So those concepts, if they keep in their counseling, that will help both ways, sir.
Yes, I do think that these four things, the essential, especially the skin to skin care and initiation of early breastfeeding, should be given in the antenatal period itself, because many a times these postnatal mothers do think that I have paid a lot of money to this hospital, then why should my baby be kept on my chest or abdomen? They should have kept in some hi-fi things like that. I'm not exaggerating. These things happen. Okay. Yes. You finished.
That's and finally there should be a good handover, and that means the clarity of information should be there, because we all know that the education level does not matter. It is about how well we communicate and tell them this is important and this should be followed up. So that kind of documentation should be there, and the set standards are available from the NNF and WHO. That will help both the doctors, families, and nurses. I think that should be there.
Yes, that is a very important message that you have communicated, because there should not be any difference in the counseling things that we communicate with them, and also it should be a prefixed and also pre-planned, and we have to document everything, and that should be, we should actually act as a nurse-doctor combo. But I do really feel that our pediatrics and neonatology, we do doctors counsel by parents a lot, because what I have seen in that other departments, like, I'm not criticizing anybody, because in the labor room or even the decision of a cesarean section is communicated by the staff nurse. So I have seen that. So we are far better, I think. Okay. Now, Ms. Harsha. Again, go on. It's not working. Just I want to ask Ms. Harsha Shri, what is the role of this staff nurse or in the infection control? When we come to newborn, we speak a lot about infection control and the prevention of sepsis, because we do a lot of hand washing. We have a protocol of doing a lot of hand washing. We do have a protocol of using hand rub. But do you think that it is really done in the practical level, or what all things you do to make it happen in your NICU, like an infection control nurse? Because many a times I have seen that even if in one duty, if you assign the role to one nurse who can command even or the order of the hospital, you do make a change, because her sole duty will be to monitor the infection control practices of the staff, including the doctors, including the consultant, including the hospital owner. You take an extreme. Okay. Suppose if the hospital owner is a neonatologist, he comes to that NICU, and she can even command over that person. So what do you think? What do you think your take? What is the take on this?
Hand washing techniques.
Yeah. So anything about the bundle care approach? That bundle care approach means that if you are doing a procedure, you will have a prefixed things. That is, you have to take that. You have a prefixed list of things, check to-do list, so that we will not miss anything. So do you practice something like in your NICU?
Surgical procedures. Hand washing.
Yeah, hand washing, and also this procedures like ANTT, that the aseptic non-touch technique you can practice. So my question was about this nurse who is strictly implementing these things in the NICU, so that he or she doesn't miss any bacteria coming into that babies, and we'll be able to do strict hand washing and other infection control practices in the NICU. Okay. So my question is next to Dr. Satish. So I already told about these things. So what do you think that the basic management skills that you expect from a neonatal nurse? That is actually, suppose you are sleeping in the middle of the night in your hospital and one baby crashes and you are driving back to your NICU and what all things you expect your nurse might have done by that time. So that,
sir,
yeah.
before that,
So actually the answer to the nursing staff and also the budding nursing students here. Yeah.
We should have a good criteria for interviewing for the nurses.
Yeah.
So we should have selected a nurse before that only, rather than waiting for a bad day. So in terms of management skills, when we mean management skills, I think they need a bit of more treatment skills as well. So when we talk about that, the nurses in certain parts of it, in UK and America as well, they have extended the role, not only just being nurses, that are being nurse practitioners, that they're taking a little bit of doctor's job as well. But however, the decision making capacity should always be supported for a nurse by the doctor. So there, whatever the decision they're taking should be supported by a doctor or advised by a doctor, so that everything remains safe. So what I would expect is they should be having the basic, as I said before, the warms, keeping the baby warm, delayed cord clamping, and also making sure assistance for the breastfeeding. They should be well versed with it. And also kangaroo mother case, they are the top priority. So those things should be there in their basic skills. But apart from that, if you ask in the NICU or outside or in a ward or somewhere where the babies are looked after, then they should have certain skills to identify that there is a neonate who is high risk or born to a mother who has certain problems. So that kind of skills should be developed for the nurses in terms of gathering the information and also identifying the sick neonates who is not breathing, who is apneic. So that kind of information they should be able to pick from the clinical skills. And in terms of the procedures, I think this is all debatable. Everybody can debate on this. But my nurse, if I am expecting that I will make her learn definitely a basic bag wall mask ventilation and how to deliver the oxygen in a best possible manner, not giving problem with the overdoses of the oxygen. So those oxygen delivering modes, they should be aware, and also the basic bag and wall mask ventilation. And also IV access, if they're able to do very well, as you said, having the aseptic precautions, cleaning hands, hand hygiene, all those things, if they are practicing, they are the main delivering care for the babies. So they're handling the babies. So therefore, the less risk of sepsis as well. So those kind of things, if they learn and we make them learn, it is going to help. At the same time, any emergency drug like adrenaline, they should be, what do you call, given safely in an appropriate way. So they should know 2-3 emergency drugs, and also, if possible, NICU nurse, a big center, they should know how to make those dilutions, and especially that kind of things. Once they acquire the basic skills, they can go forward to the advanced skills really. So like that, we can enhance their role definitely, because they are present in the ICU most of the time, sometimes more than us sometimes. So their role can be extended.
Not sometimes, all the time, I think.
Yes, sir. Yes, definitely.
Because the main idea that we want to convey is that newborns cannot wait. Because sometimes an adult or a pediatric patient can wait. But newborns cannot wait. If you make them wait, you know what will happen. So you'll not be there to receive our expert management. So don't make them wait. So the best person to deliver of the best management, I do think, not a hi-fi thing, but a basic thing. So the babies will be good nurse who is practicing the NICU. Yeah, another one is dealing with the difficult patients.
Yes, I think this is one last thing I would definitely say is that because they are there, okay, they will get some hints or cues what's happening with the family really. So they should be able to pick and tell us really if there are some difficult attenders. Okay, this should be part of their role as well, and that will help the entire team definitely.
Because they'll be seeing that families, they'll be seeing the bystanders 24/7, and we will be seeing them during the counseling or any other important decision-making things. Only we will be seeing them. So the subtle things, they are very nice or a very expert person to catch. And whenever the things goes wrong, you can make them first, in front of you. And many times we can
Yes.
Yeah, save our faces. They will not by them, because we'll be able to know what is happening with them, or we will be able to prepare us in a better way if they
Yes.
are there.
And
Yes.
and other thing is that whenever there is an unexpected death, because that is going to happen eventually, any NICU, busy NICUs, baby will be normal. Suddenly things change, and it's unexpected, totally unexpected. So that kind of emotional context, not only doctors, the nurses should be there, and they should understand that this can happen and what to be done in that kind of situation, and just being gentle with the families really, rather than using a irresponsible language. I think that would be helpful.
That is very important. That is very important, doctor. So, moving on to Dr. Karthikeyan. So we will be having a lot of issues in the postnatal wards. As one of them is the breastfeeding issues. So what do you think? What are the major pitfalls or the practical issues in lactation management in the postnatal ward? Because we will be able to make use of the neonatal nurses or lactation counselors in the postnatal. And I'm speaking about the postnatal ward, not in the NICU. In NICU, we will be using different things like that EBM, or some of the units will be having these breast milk banks, or sometimes we have to use formulas, all those things. So what are the basic breastfeeding issues or lactation management issues that you have come about in your postnatal wards mainly?
Yeah,
And
like
how can we make use of the nurses in that?
yes. The our basic policies of baby friendly hospital initiatives, where the concept of lactation should be counseled at when the mother is in antenatal period itself. So where the role of lactation counselors or the nurses have a crucial role in this, because we all know the importance and advantages of breastfeeding, and the concept of maternal nutrition, especially the antenatal nutrition. These roles should be taken by the nurses, and these are definitely the pitfalls or the practical issues which we are lagging, and the exposure to the formula usage, again lagging in breastfeeding failures, and like the collection and storage. We have got different policies and guidelines for all these storage of breast milk, where the mother is really sick and the baby is deprived of the mother milk. We have got human milk storage banks, and these awareness should be done by the nurses to the mothers as well as the family members who are already bereaved. Uh, so these pitfalls are to be concerned by the nurses.
Yes, that's true. Because an neonatal nurse or a nursing counselor or a lactation counselor can do a lot of things in establishing the breastfeeds as well as promoting the breastfeeding for the baby. Because it is very simple to prescribe a formula and mix them to give to the baby, but it is very difficult to just to get the simple breast milk. So we are making things complicated many times because of the absence of staff nurse. So my another question is Dr. Shashi Reddy. So many times we know that we will be reaching your NICU by 9 o'clock or 10 o'clock or somebody afternoon. We expect our neonatal nurses to take the rounds, isn't it? If you are having the comfort of having a lot of senior SRs, it's okay. But many times SRs are not available. So the nursing staff will be doing the routine rounds because they will be taking the 24/7 rounds to different things. So what are the important essential rounds that you expect your nurse to take or to report to you if something goes wrong?
As we all know that NICU is a team effort. What the thing is, we have to remove, as we are removing shoes outside the NICU, we have to keep our egos also outside the NICU. Because we have to train our nurses.
Yes.
Because they are the crucial part. Even whether it is a big unit or small unit.
I have seen in front of the cockpit of some airline that all your family issues are their family. Beyond this door, there is no egos. Beyond this door, there is no family issues. Beyond this door, there is no egos. I think it is Indigo.
Yeah, this
If in the cockpit you're fighting with your wife, it will be very difficult for you and for the passenger.
For that only, sir, only in NICU. It is a disclaimer, only in NICU where keep for egos.
Yeah. It will be displayed in front of the NICU also.
Yeah.
That you think, yeah.
The thing is, because the skin, that is an important organ, and largest organ for a tiny baby. Even though for adult it's okay, it is a tiny one that itself will make the focus for the infection. So whenever there is a skin, you have to see for the color. Apart from jaundice, cyanosis and all mottling and the pale. as a ominous sign. We have to train them. Along with that, we have to see for the integrity and the breakdown. If there is a breakdown, because of plaster and all, we have to be very careful while removing a plaster, while application of plaster, wherever it is, for a cannula or a warmer, wherever it is, it has to be softly and gentle while removing. Along with that, we have to see for the any rashes, like maybe due to diaper or physiological rashes, has to be notified, documented, and that has to be, we have to teach the staff, whoever it is there, resident or a staff, to handle it carefully. Regarding the lines, we have to see for the color. That is the most important. If it is a signs red or warmth, it means there is a phlebitis. If it is a cold, infiltration. Because it is mostly the NICUs will have infusion pumps and syringe pumps. It will go on dispensing the drug. Whether it is a patent, whether it is extra vegetating, it won't sense. So you have to see that. If it is because hypothermia itself kill the child, even though under warmer. So you have to see for the temperature properly, how it is there at the time of insertion, and the pain, or the baby is crying, or a baby having irritability, new onset of irritability. Definitely it is because of pain. Based on the pain score, we have to see that. And most important thing is a dressing. It has to be transparent dressing, which are the most of the units will see that white plaster, especially in a government setup, will close it. Or it has to be like a transparent tegaderm to see for the how was that tip was any bleed, whether it is a soaked or so. In such cases, you have to remove it gently and applying that minimally adhesive tapes, hydrocolloid tapes, and gentle cleaning with a soft, low pH soaps has to be there, or solutions has to be done. And we have to check the skin integrity at least once a day to see for any pressure source. If there is, because there are the more source of staph infection in the unit. Then coming to the long lines, you all know it, it is a cath related bacterial infection. So you have to be very careful at the time of insertion, during the procedure, daily rounds, the plaster has to be normal. You have to always cross check by x-rays, whether it is a PIC line, whether it is a umbilical line, the position has to be checked at least once. If there is no free flow, if there is an extravasation, you have to be very careful. You have to remove the lines. ET tube, you all know it, that indicates that whenever there is a kinking, when the baby is giggling, when there is a drop in saturation, gentle thing, suction has to be there, and that. Drains, especially in ICUs, in our setup, these are less, but in case of other setups, level 3 or level 3 plus, they can have ICDs. The ICDs also have to see for the how much the collection, whether the drain is there, how about the bubbling system, because that shouldn't have a complication. That regarding that daily rounds, you have to see for the equipment check. Prior to that, every day, each shift, at least once a day, you have to see for the whether ventilator backup is there, ventilator power source is there. So whether they are all calibrated, service are done, when the service has to be there, has to be documented in our logbooks or logs. The backup readiness, suppose there is a power failure, a generator also not working, you have to keep our ambulance at least one at place to cope up the ventilated babies. All these things has to be documented and has to be reported to the person in charge in the end of the each shift or SOS. These are the things I think daily, each shift we have to do. If we do that, we can cope up that unexplained emergencies or unwanted things in our unit.
Yes, especially about these long lines, also this, if you CPAP interface, cannula rounds, usually what I used to tell my staff nurses is that when you're going to feed the baby, when you're going to give the feeds for the baby, just have a look, any redness is there, any that alarm is coming, or any infiltration is there, any leakage is there, just look. One look can save sometimes a lot of lives. So just I want to get a key points from Ms. Harshasri that what are the practical issues as a nursing officer? I want your opinion from as a nursing officer. Do you face in managing not babies, in managing the ICUs? So that comes baby level, doctor level. So doctors are also very difficult persons. Doctor level, bystander level, administrative level, everything. So can we be brief in 1 or 2 minutes, like the headings only, so that we will have an idea?
Crisis management, technological and equipment issues, support for parents, communication challenges, physical space constraints, workload, nurses burnout, violence in healthcare settings.
So these are the one of the main things that happens usually, that this sometimes nurses will be asked to take long duties without any breaks. So they'll be asked to do the things, and also other thing. The second one is coming up in our society, like violence to healthcare settings. They'll be attacking those healthcare staffs, not only the doctors, also the nurses, and also this again gone. Yeah, we'll do. We'll do. It's not working. Again, not working. Previous one. Yes, that is inadequate support from that hospital administration. All those things, usually the problems that the staff nurse faces. Yeah. So this is the nutshell. These are the inadequate staff usually goes to nurse burnout and lack of support from the hospital administration, busy NICUs, difficult bystanders, and difficult doctors, and all these things will cause ultimately the increased chance of errors. So we know that NICU is a place of error sometimes, and I just want to know about from Dr. Shashi, how often you face this errors in NICU, or what are the things that you can do to minimize those errors in the NICU?
Yeah, once upon a time we had, sir, but now it is almost negligible.
Yeah,
Because
just,
of
just
in a
enlighten
government
us how you able to came down
Yeah,
on
the
your.
thing is a staff training, sir.
Yes.
That the staff has to be trained properly, as I mentioned earlier, the residents, and the standardized protocol for the taking over, handing over. Suppose they're main because of burnout by nurses and doctors, there are chances of getting the wrong things. But one thing, whatever happened, always be transparent. Sit with the parents, document, explain them they happened, and the interventions what we did, what are the observations with empathy. Definitely they'll understand. Only thing is you have to be open up. Then at the same time, you have to monitor things. You have to document the things so that the most of the thing we can be prevent, we can fight legally. If we are not transparent, definitely we'll be under level.
Yes. So the transparency is the important. So something happens from your side, be transparent, and so the more you try to hide, the more lies you have to tell. So be transparent. I know being transparent is not a very simple job, but try to be transparent. Okay. Now, just I go to Dr. Karthikeyan, or just I actually this question was I intend to put to Dr. Nagalashmi, who is an obstetrician, because Madam has some personal emergencies. Madam was not able to come. So pediatrician is taking the obstetrician's question. So Dr. Karthikeyan, so what are the roles of a staff nurse in caring the time or preterm lady who is going to deliver soon?
The previous discussions being happened, staff training is more important. So they should anticipate the challenges or the problems likely to happen in term delivery and preterm deliveries, and from the maternal point of view and the baby point of view. So like some of the points like antenatal breast examination, how the mother is ready for lactation soon after delivery, even though it's a preterm baby also. And the essential newborn care principles, that is skin to skin contact, early breast initiating, and maintenance of temperature. So all these things the nurse has to be trained, and she should be trained enough to communicate whatever she has learned to the mother in the language known to the mother. So it all depends on one-to-one
Yes,
education.
the message is
status.
clear, doctor. The message is clear. That I think we already talked about these things in the previous questions also. So my last question is to Dr. Satish, and we talked a lot about or administrative level, medical management level, errors, sort of things. So what is this? This is a very important thing, isn't it? What are the medical legal obligations of a neonatal nurse, not from the doctor, from the nurse? So something actual accident happens, or some wrong drug is given to a wrong baby. Okay, I know that vicarious liability comes to a doctor, but what is the obligation of a nurse? That I want to know. Sorry.
So medical legal issues are common for everybody. Whoever is working, whoever is in the healthcare sector, they're all common. But it is the mode of responsibility, how it shifts from doctors to nurses. Obviously, the law and regulations are going to be the same for everybody, whoever is working there. It does not matter. It can be partially given to one person or partially given to another person. But the problem we have is we should be very aware of what clearly the legislation says and what does the law allow us to do. Because by default, the presumption is that everybody is going to give the very good care at the set standard. But it may not be possible all the times. So we have to understand that nobody can be perfect at all times and trying to be prepared for these kind of medical legal issues. From nursing perspective, I think majority of the times in ICUs, we see is the treatment errors, or one has been given a good prescription, but they have not been able to deliver it in the same manner. So treatment errors and irresponsible language and talking in a irrelevant manner to the families will bring some medical legal issues. But what is the punishment does not matter. I think we all should be aware that it can be a combination of things. It's not one single error that will lead to the complaint. Because if we want to be medical legally covered ourselves, we should believe that we should work in a manner that its entire things are really covered. Not one single error will lead to that. But definitely the nurses are also more and more prone physical violence. So if they are in the beginning in the front line, they are bound to have some physical violence along with the doctors as well. So it's nowadays a fashion. So we have to learn certain personal skills as well, how to protect ourselves, and then ask the institution. Because
what are the personal skill you expect us to?
So we all have to go for definitely kung fu, yeah,
karate,
we have
all
to.
those things.
So make you feel more confident whether you confront or not. At least you will be more prepared for that. One day will eventually, I think it should be programmed into neonatal and medical training as well.
Yeah, that can be another workshop can be conducted for this.
Yes, absolutely.
Self-defense in course and
Yes.
other medical things. Yeah.
Definitely. I think the medical legal awareness, not only for doctors, the nurses should understand that in abroad, definitely they are more aware because they can be penalized. They have to answer to the council themselves. Doctors are not always there to protect them because certain things cannot be forgiven. So therefore, the severity of the medical legal issues, they should understand as well. And sometimes most important is the handling. So I have seen complaints that that nurse is really handled baby roughly, and they complain directly and violence to the nurse as well. Okay, that can happen. It irrelevant. We are not aware what happened. You are not there. Management is not there. Doctor is not there. So the neonatal nurses should know how to handle the babies and how to speak to families. Otherwise, things will get more complicated from that point onwards.
That's true. I actually heard a complaint from the bystanders that Sara avളുടെ നോട്ടം ശരിയല്ല. That in Malayalam that means sir, that doctor, the way she looks at me is not right. So that was the
father.
So you will get a lot of funny complaints like this. Okay, jokes apart. Yeah. So you come to the end of this final discussion, and just I want to have one message from each faculty to the group. One message, single word, single sentence, not word.
So protocols are not only for the pediatrician neonatologist, even the nurse has to stick on to the protocol to reduce the mortality and morbidity.
Yes, doctor.
Learn, unlearn, relearn of the SOPs on regular basis.
Yeah, that's for all, not for the nurses, for ours also. Yes, sir.
Counseling champions and medical legal awareness.
Yes. Harsha.
Adequate staff.
Yes. I think that must be the sole takeaway today, that staff should be adequate. Okay. If you make work 10 persons work to 1 person, things are not going to happen. So as Mr. Harsha has told, adequate staff, that's only one sentence, one word is needed. Adequate staff should be there. It's competent or not competent, that's a different thing. Actually, the person should be there to make them competent. So that come to the end of this final discussion, and we think that strong mind discuss ideas, average mind discuss events, weak mind discuss people. I do think that we have discussed some ideas, even though it is not complete. Thank you, and we are happy to take some questions from the audience as well as from that Zoom platform. I cannot access Zoom here, so you can project the questions here. Questions are there. 2-3 questions have popped up. Very pertinent questions raised. difference. Yeah. Dr. Amit has asked difference in the points raised in counseling between two caregivers, be it two doctors or doctor and nurse, can cause big issues. Even on non-issue topic like volume of feed, amount of urine passed, which can be irritating. So if not sure, one should say just check and tell. Yes, that's an important thing. Should not hesitate in front of the bystanders that don't don't lose track in front of them. Doctor, how much feeds are you giving? I'm giving 10 ml third hourly, like 10 ml second hourly. But the sister told that it is 20 ml. Then you are stuck. If you don't know, just I cannot say the 15, 20 patients are, I cannot remember all those things. I'll check and tell you. A simple thing. Yeah. Go down. Unexpected death as soon as the baby worsening is known, two persons, resident doctor and nurses, should initiate resuscitation, and one person staff should send an emergency call to doctor in charge. That's a comment, I think. Team management. Yes. Then down. That's the last one. Okay. So that's only the question, that the comments from that online delegates. So any comments or suggestions or questions from the delegates is highly appreciated. Actually, it was a very good learning experience for us also. A lot of staff nurses are there, a lot of students are there. Because we want to hear from you, because our things are going to over. You are the future of this neonatal health, neonatal management. Nothing.
I think one point, sir. I think asking for help is important for them.
Yes.
They should be allowed freedom to ask for help. From doctor's side, I think we should not try and be as a big boss and not allowing them to ask
Like
freely.
Sarah's called egos apart. Egos apart while you enter in the NICU. If you cannot intubate, just call your help. Call your friend. Like that, nurses also. Something wrong, you don't know, you cannot understand. Just call and inform others. You'll get at least a relief also. Okay, I have informed somebody. Counseling should be done together so that is no confusion. Dr. VK, Parvati madam is from my place only, from Thrissur. Yeah, madam has already told that. Yeah, madam has taken the point of a doctor-nurse combo in counseling. Yeah. If there is no other questions, shall we wind up? I'd like to thank all my panelists. All four persons have done a wonderful job in preparing all those answers to my silly questions, and they have done excellent job. Thank you. I am not enumerating your names. So thank you all of you. Thank you.
Thank you, sir.
So it was a good onset to the online CME. Many enthusiastic people here and a lot of learning experiences. So we'll move on to the next panel discussion, which is again going to be on a very relevant topic, that is NRP and management of birth asphyxia in resource limited settings. By resource limited, basically we meant like a country like us where resources vary between places and other things. And how to translate the evidence which is available for our own practice is going to be the crux of this talk. And to do justice to this talk, I invite none other than Dr. Tejo Prasad. He is a senior consultant at Fernandez Hospital in Hyderabad, and he will introduce the panelists for this discussion.
Thank you, Dr. Giri, for introducing me. I would like to invite my colleague panelists who are very experienced and then working in different sectors here. So we have four distinguished panelists here. Dr. Naveed from Kurnool Medical, from Kurnool. He's from the KIMS Cuddles there, and he's heading the neonatology department. Dr. Jagdish, so from Tirupati only, so from Ankura Hospital. He's in the department in Ankura Hospital, Tirupati. Dr. Venkat Suresh came from Nellore now, from Kids Rich Hospital, Kids Fine Bona. And Dr. Muni Mohan, lot of claps. I know that he is from the local. Everyone recognizes that he's a local. Okay, so for the next, we'll try to cover it in 30 minutes so that we'll have some 5-10 minutes at the end. We wanted to utilize our resources much better way because our topic is also on the resource limited settings. The first question I want to pose to my panelist is that Dr. Jagdish will tell us about, actually, does it cost so much while you are doing the resuscitation? How much is the requirement of the equipment and other things reusable? We will look at it and then we'll come back. Jagdish.
Yes. Good morning, everyone. So I want to divide these equipments for resuscitation into single-time investment equipments and reusable and single-use equipments. So initially, see, the radiant warmer is the one which cost a lot of amount. You can see there any radiant warmer is the market you can get at 60,000 to 70,000 rupees, and like that laryngoscope, oxygen cylinders, and suction apparatus. All these things will cost around 80,000 rupees. And single-use equipments like single-use and reusable equipments cost around 4,000 to 5,000 rupees. So all the equipments, in short, we can. Sir, can you go to the last slide? So all the equipments like your ET tubes, orogastric tubes, syringes, medications, all these will cost just 3,000 to 5,000 rupees. The point is that when we invest 3,000 to 5,000 rupees, apart from single-time investments, we can save the life of a baby, like self-inflating bag, everything we can get within 3,000 to 5,000 rupees. The bag, ambu bag with reservoir cost is around 900 to 1,000 rupees. A lot of brands are there, we can get. So I think if the T-piece resuscitator is also available, that is a luxury for in a low resource environment. So I think the total equipment cost for setting in a low resource setup is around 80,000 to 90,000 rupees.
So we can round it off to around 1 lakh.
1 lakh.
So 1
Yes.
lakh is not a very big amount in the current scenario if you look at it.
Yes.
Because it is a crucial area which we are dealing with it. Either it is in the postnatal ward or in the delivery room or in the operation theater where you are keeping the resuscitation bay is very important and critical area in both the perinatal, any of the perinatal units that we are looking at. So as a single time investment, at least one resus bay has to be there. Ideally, we should have 2 resus bays at all the areas because when you have
multiple deliveries,
twins which are coming or triplets which are coming, you can't rush a warmer at that time and then it will be very difficult for you. So 2 sets of things should be ready always at any given point of time in the resuscitation bay, especially to get prepared for both the multiple gestation, and sometimes it could be that 2 deliveries might be happening at the same time. So we need to remember about this. Yes, as Dr. Jagdish told you that initial investment may not cost you much. The main problem comes is the apex. I think Manohar sir is laughing at me because every time we have to keep the indent for it and then you have to bring the replacements. So ensuring the replacements of the reusables is the most important thing while we are dealing with the resuscitation bay, and we should try to ensure that these reusables are there at any given point of time, whether it is in the morning, night, or in the evening. We should have one
set
available set there and one as a backup set, because again somebody has to prepare on the same piece. So we usually keep in a high load unit, like when you have a 15-20 deliveries at least per day, 5 sets should be ready at any given point of time, so that you need not again prepare all the things and keep it in any of the bags, so that it will become much easier for use rather than again going and then searching in your racks and everywhere. So it will become difficult. Okay. So next one is that, is it the training? Because we discussed in the previous panel also, we have the people, but somewhere I think we know that the Ms. Harshasi has told that even the education staff is also not much of the issue. Is it the training or the resources? Again, the resources includes both the human resources and the reusables, which are more important in doing the good research.
I think, thank you. Good morning, all. I think both are crucial, the training as well as the equipment being present. But I think training is the most important aspect in any neonatal resuscitation. Because time and again, we see that many people who are attending deliveries, the birth attendants, may lack the basic resuscitation skills. And also their ability to recognize that the child needs resuscitation or to start the resuscitation, to get an idea that this baby needs help is very important. So this training is very important. Again, it is not one-time training that is important. We need, like, it's not like you have done an NRP training 10 years ago and you have not refreshed yourself. As from the guide, we are seeing that every few years the guidelines are changing. So the staff should update themselves with the new guidelines. With evolving knowledge, we are changing with our guidelines. So they should be well versed with the guidelines. And again, the last point is very important because we see many trainees, they are not able to give proper seal or proper, simple bag and mask ventilation also may not be up to the mark. This can have a great impact in the outcome of the baby. Regarding the next slide. So regarding the next point in this is the resources, right? We know that all the equipment may not be available in a resource limited setting, because when we use the term resource limited, we might be in the peripheral settings, we may not have a good warmer or a good bag and mask ventilator, good ambu bag, and also maintenance issues, because sometimes they purchased it but they have broken down and they have not, not been able to get it repaired. So the equipment maintenance issue is also very important concerns in a peripheral setting. And availability of drugs can also be a problem, as we know, like getting essential drugs. But again, in the end, if you have to choose one of them, it will be the training, because even with minimal equipment, just a basic warmer or and a good ambu bag, you can save many lives. We all know that point. And studies have shown that good focused training, you can save many lives, as was shown in the Helping Babies Breathe campaign. Nearly 47% of mortality was reduced in that study or in that training program. So training ensures that the resources, whatever are available, can be utilized properly, and many lives can be saved. So I would pick up training as the most important aspect in this. Okay, and also the investment in the training programs, like I was saying about Helping Baby Breathe campaign, many lives could be saved with just having a bag and mask and a warmer and some basic towels. That was a part of that campaign. So sustainable training and regular refresher courses are very crucial to improve the neonatal survival.
I think Dr. Naveed has emphasized a lot on the training. So training means training everyone. So the people who are entering into maternity and neonatal ward, everyone should know the basic NRP, including the fourth class employees. That's what I always feel. Because if they also are in the same momentum, they will at least procure you the things which are required for the same. And it is whether it is an obstetrician or a pediatrician who is entering into the delivery room area in the postnatal ward and everywhere, we should all be trained enough to do at least a basic NRP. And yes, the advanced NRP can be done by the people who are more experts than them. And the periodic refresher course also will try to help on the same. Can we utilize any newer methods, Venkat Suresh? Because nowadays a lot of new techniques have been proposed for the better skill retention. That's what people are looking at. Even the MCA also, now NMC, is looking at the faculty developmental course and then for improving the medical education.
Yes, sir. Real time training is not possible always. So newer methods, they help us for better training and better retaining of skills. And NRP, like neonatal resuscitation, is a, we all know that it's a team approach. And simulation based training nowadays, simulation offers a better advantage, like better hands-on training. And if a person makes some mistakes, we can correct there itself, and we can get the feedback also. And after the training session, debriefing, like what are all the mistakes we have done and how to learn from those mistakes. So these debriefing and feedback sessions will help. Um, and this will guide us for better improvement in the real-time scenarios. And nowadays, newer technologies like virtual reality, augmented reality, so where there will not be any baby will not be there, so we can directly, like we can feel that chest compressions you are doing and bag and mask you are doing. So these will help us for better learning feeling, and it can be easily reproducible. With many participants can be trained at the same time.
Remotely also.
Yes, sir. And these are all the training videos and pictorial approaches where training of basic basic training modalities can be, we can adopt these kind of pictorial materials. And we know that continuous education is a paramount importance. So we have to, as Sir was discussing, frequent refresher courses will help us better retaining the skills and better applications in real-time basis.
How many are doing the simulations here? Very good. So nurses, how many are aware of simulation scenarios? PGs, how many are aware of simulation scenarios? Everyone is aware? How many have done it hands-on? Okay. So nowadays, that routine classroom teaching or a blackboard teaching is getting out of fashion because the retention is lesser. And second thing is that what we are seeing, the new generations, especially the Gen Z and other people who are coming to the work now, are no longer interested in this blackboard teaching and everything. So they want something different to retain their skills. So definitely a simulation and debriefing. Debriefing has to be more focused. At the same time, very at the same level you have to talk. You can't be like a boss and then the other person is like somebody's subordinate and then do it. Otherwise, the retention, the message what you want to convey may not go. And the virtual reality is the another thing which is getting utilized in the education space. There are some challenges in the virtual reality also. As he said that we can simulate a room, but the main problem is that the haptics and then the feedback mechanism which we have to give it. Ideally we should have that gloves which will come. You can wear the gloves and then try to do the simulation. The problem with the gloves is that too costly. The VR camera is not much costlier now because that is coming less than 1 lakh only, roughly around 40 to 50,000. You will get the reasonably good camera. But the main problem is with the gloves and then identifying the things. When I talk to the people who are doing the virtual reality in the gaming and other things, who are working in the gaming sector, especially because all the virtual reality has been more utilized in the gaming sector, and most of you might have done that Xbox and other things also, I feel. Main problem is that uptake, how many people will opt for it. So that's the reason why they do not want to invest on the education sector. But if all of you will try to go for it in a message and other things that we can utilize it, maybe the gaming industry also will try to help you out, because there are many gaming industries who want to contribute to the health sector. So on the same, I am trying with one group, but let me see how much it will try to help out. Okay. So these are the things we need to look at it under retaining the skills. So you need to practice, 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 and then we can try to look. Okay. So we looked at the costing and then training and other aspects. Dr. Manimohan, how actually we can do in a resource limited setting, because thermal management and the respiratory management are the most crucial part in the NRP, because 90 to 95% of the babies, if you take care with these two aspects, I think you are done.
Yes.
Okay.
So sticking to the basic NRP, so maintaining the delivery room temperature 23 to 25. Not only the problem is hypothermia, here hypothermia also very common in case of South India. So maintaining temperature to 20 to 25, and whether the baby is delivered by cesarean or by vaginal, preterm, term, cried or not, all the baby should delivered on skin on the mother's abdomen and start the skin to skin contact, and warmed linens. So we need to put the linens 20 to 30 minutes before the delivery and warm them, and basic hat, gloves, socks, and keeping the radiant warmer ready. And whichever baby is delivering less than 32, polythene plastic wrap will is a literally good game changer. So these are the basics we can stick to maintain the thermal management.
And that doesn't require any cost.
Yes, yes. Even the food grade plastic is good enough to maintain. No need of any purpose made plastic wraps. So out of this, for the transport options, the age-old technique is that putting the baby on concurrent mother care, but we need a lot of obstetrician coordination for this. Most of them, they're not sending now. So from the district hospital to the tertiary care. Incubators, transport incubators nowadays, 108 neonatal ambulances, almost every district has in 2. So they're having transport incubator, but none of them know how to attach a probe and how to the temperature to set. So they need a lot of training. So, and the simple swaddling, cotton swaddling, putting a cap, sock, glove, that will give decrease the hypothermia. As we know, the admission temperature is the important prognostic factor. One of our PG's thesis is that she observed 75% of our babies who's received from periphery have a cold stress or severe hypothermia, and out of them severe hypothermia, the mortality is 50 to 60%. And embrace is the really good one. So embrace is costs 10% of the transport incubator, which is works on a phase change material, which also helps in maintaining the baby temperature. So regarding the positive pressure ventilation devices, I know the most of the centers are not affordable for the TPs resuscitated. So, but till the bag and mask is the main thing for us. But there is a lot of advantage for CPAP. It provides consistent pressures, and it also provides PEEP also. And FiO2 is a very, you can titrate with the blender, this one. And for the PEEP valve, recently we got a donation from foreign countries that the AMBU with the PEEP valve, so that consistent presence. So the pneumothorax came down, and lung protective status are more now. And so what is the future? So Indian made TPs resuscitators, which are costing almost 30 to 40% of the imported ones, is the future. So we can order more, and we can put lot of requests to the government to get this resuscitator, so that we can use appropriately. Air oxygen blenders, even though it's nowadays medical colleges are provided these things, but nobody knows how to use again. So we need to have a lot of training, but lot of newer things are there, ventures are there, and air oxygen blender charts are there. According to this chart, we can use air oxygen with a Y connector, where you can do, suppose if you're putting around 5 liters of air and 3 liters of oxygen, we can get the 50% of the FiO2. According to this, we can titrate the pre-ductal saturation according to the NRP algorithm. So, and the new study recently came that if you titrate the flow rates from 0.25 to 5 liters, we can increase the FiO2 from 40% to 100%. So all these things, only through sticking to the protocol, knowing, and the lot of attitude change, because there is no resource limited setting nowadays, because NHM is there, and NHM is giving everything. So recently we got 2 cooling machines here in Tirupati, and almost 6 medical colleges in Andhra Pradesh got 2 machines in recently. So everything, we have transport incubator. We recently TP is also coming to us. There is no resource limited setting. Only training and maintenance is the important thing. Thank you.
Great, thank you, Dr. Munimohan. How many are using the blenders in the delivery room as of now? Front line, back. Delivery room. Sridhar sir, okay, you're sitting at the back, okay. So it's very important that we should try to utilize that blender also in the resuscitation room. Blender costs around 20,000, not more than this. Less than that, 15 to 20,000 is the thing. If you have the central oxygen, you can connect, or you can utilize the air cylinder and then the oxygen cylinder, and then try to do the mix and match also, the way Dr. Manimohan has told us. So it's very important, and it is a norm now that for all term babies, you should start with the room air. And even in the preterm babies also, you should start in between the 21 to 30% of oxygen only. So we often ignore that I'm just only doing for the 2 minutes, 3 minutes resuscitation, and then we'll continue with the resuscitation. So even that exposure to high oxygen in the first 5-10 minutes has been shown to have a long-lasting effects. Please try to utilize the blender, and you can, once you raise your voice, then only the administrators also will try to address on the same. There are some blenders, integrated resuscitators also, which are available in the Indian markets, which are turbo driven actually. So the air will be sucked in from the atmosphere, and oxygen you need to connect it and then try to utilize it. Those are also available, which you can try to utilize. Okay. So the next question is to Dr. Jagdish. How can we ensure that disinfection of the routinely used resuscitation equipment? Because that's one of the important things. Sepsis is one of the biggest killer in our country.
So as we all know, sepsis is one of the important factor involved in neonatal mortality. We all know that Spalding criteria of disinfection, which states there is critical equipments, semi-critical equipments, and non-critical equipments for disinfection. So neonatal equipments come in semi-critical category, which is that these are the equipments which are in contact with non-intact skin or mucous membrane, which required ideally sterilization. Sterilization is removing bacteria, fungi, and including spores. But disinfection is the one where spores are not removed. So neonatal equipments, all these essentially is a high level of disinfection. So next is that we can see here, it is in US where there is it's an highly resourceful setting, reprocessing of equipments. There is a pre-room with pre-room, preparation room, then a processing area clean ideally with equipments, PPE equipments, and post reprocessing, there is a clean storage area. But in low resource setting, all these things are not possible. And so that in 2016, there was a guideline come up by path guidelines, which states that there are preparation area, pre-disinfection, disinfection, and post-disinfection. All these things should be carried out in low resource setting for reprocessing. Is it possible? It is very tough because there are many challenges involved in disinfection in low resource settings, like we don't get dedicated personnel like nursing personnel or whoever, dedicated personnel for reprocessing. Cleaning solution will not be able to change frequently. Equipment will be put in the chemical solution for prolonged time or less time, and equipment disassembling is also will be difficult. And all these things are the practical problems involved in reprocessing of equipments in low resource settings. So what is the ideal way going forward in future is there are 3 future considerations we can do. Making the path guidelines to be simplified, like we cannot disassemble all the bag and mask equipment, there are many parts, as we know, in the bag and mask. So at least the most contaminated part is mask. So at least we can ensure that disinfection is carried out at least for the mask part. And like dedicated personnel should be provided, and adequate funding should be there. And one more important thing is like in NRP, as a part of NRP, we can include training for the staff how to disinfect the mask and all the equipments. Since we know that there is a high mortality with sepsis, it is better to incorporate as a part of like a 5 or 10 minutes training to all the nursing staff and doctors, so that how to disinfect in a low resource setting. I think going forward, this will be very useful.
From the PG side, can I know how many times you have to clean your self-inflating bag, and how do you do the disinfection? So nothing new. We don't concentrate on this. Okay. So every person who is working in that area should know how to clean the critical equipment, because you are using the self-inflating bag almost every day in and day out. If we do not know on how to clean it, it is like cleaning our plate while before we eat. So we should know how much Vim liquid we have to use and then how to do it. In the same manner, you should know that how to clean your routinely used critical equipment. Okay, I hope that this will stimulate you and go back and then read, because we do not have much time on to look at all the things. Okay, so next is that suppose you have done all of these 5-6 steps, still asphyxia has happened in the resource limited setting. I do not have a cooling machine. That Munimohan has now 2 cooling machines, but we do not have a machine. So what should we do? I mean, should we leave the baby, or can we at least do some protective strategies to improve that baby condition?
Yes, sir. We can do something about this.
Yeah.
So in the first hours of life, the first 6 hours of life is very crucial, because this is the time where most of the babies, some of the babies after asphyxia, mild asphyxia, they may recover. And we have to find out those babies who requires specialized care. If hypothermia is available, that's well and good. If it's not available also, we have to identify those babies and we should give the care accordingly. So first of all, like standard things which we have discussed, we have to, thermal care is more important. We have to avoid hyperthermia here. Both severe hypothermia as well as hyperthermia, both are detrimental. And if baby, if therapeutic hypothermia is available, if you have to shift the baby to cooling,
that will look at it.
So we should not overheat the baby under radiant warmer. And euglycemia, maintaining euglycemia is very, very important. And another issue is hypocarbia. So if baby is depressed, we may tend to do over ventilation when we are doing bag and mask ventilation, which is a common problem. So that's why we should be aware that our bag and mask frequency should be between 30 to 60 per minute, so that we are not over ventilating the baby to avoid hypocarbia. And another important problem is hyperoxia. So as sir was discussing, there are many other options how to blend indigenously. So we have to avoid hyperoxia as well. And hypotension, if baby is having hypotension, baby may require inotropic support to maintain BP as well. And this is a chart showing blending where FAO to deliver depends upon the flow rate. As sir was discussing, from 0.25 liters we can give. So FaO2 starts at 30 to 40%. So we can increase according to the saturation targets.
Sure.
And once if the baby is depressed at birth, so we have to first assess the status of the baby at birth, like standard if blood gas is available, pH, and 10 minutes Apgar score, the need for advanced resuscitation. These help us to categorize the baby, whether this baby requires any intervention or not. And in the initial 3 hours, if baby's sensorium is better, hemodynamically better, we can shift the baby to mother side. And if baby is having encephalopathy, we have to follow some standard neuroprotective measures, where avoiding high temperatures, maintaining euglycemia,
which we have
normoxemia, which we have discussed already. And fluid therapy, there is no standard fluid restriction. According to the baby's fluid status, we have to titrate, and we have to monitor for SIDH. If there is SIDH, then we can do the fluid restriction as well. And management of seizures. So clinical seizures are very common. So in the initial first few hours, if therapeutic hypothermia is not available, prophylactic phenobarbital is being recommended in the recent literature, but many future studies are required for regular usage.
That is only restricted to resource limited settings where you are not able to diagnose a seizure accurately.
Yes, sir. And serial monitoring for encephalopathy. There are many scores available, like Thompson score, NACHG scores, where we can monitor whether the baby is going to encephalopathies, to assess the severity of encephalopathy. And another important thing is monitor for multi-organ dysfunction, where, as you know, cardiac and renal, like almost every organ can be involved. So common multi-organs, like we see renal as well as cardiac systems are more commonly involved. We have to identify these clinical features. Whether the baby is landing in multi-organ dysfunction, we have to identify and treat these dysfunction early, so that baby's recovery will be much better.
So supportive care is more important by looking at the all different organs, because it's not only the encephalopathy that we need to concentrate while the child suffers from the perinatal insult. So we need to look at all the other organs also, because improving the perfusion, improving the status of the coagulopathy, and improving the oxygen status and metabolic milieu status will try to help you to come out from the encephalopathy also to certain extent, and also it will improve the neurological outcome. Thank you, Suresh. So next is that now Dr. Munimohan, now this question is relevant to you because you have got a machine now. So are you ready for it?
No, sir.
So why do you think so? And then what are the basic requirements that current NNF guidelines as position statement has come out from the same?
So
You can improve and then you can be
Yes,
ready for it.
yes. So we need to have a multidisciplinary team to have a therapeutic hypothermia. It starts from the intrapartum period itself. So first we need to have a stabilized or a good level 3 maternal care unit to have all intrapartum events to be managed well. And to be in the NICU side, we need to have a neonatologist who had a training in therapeutic hypothermia. So who would be on inside 24/7. So who is knowing all the complications and how to manage the complications. And the nurses who are with very good training in the therapeutic hypothermia machine. And the nursing ratio, this is the toughest challenge for us. So for a shift, we provided 4 for the 30 to 40 babies here. So it's very difficult to put them on 1:2, 1:1 ratio. And bedside, this is the one more difficult thing. So EEG is impossible. And focus also an important thing to look for the PPHN or intracranial hemorrhage. So where we need to stop or we need to move to other strategies. And access to MRI, nowadays it's there. So, and long-term follow-up. So nowadays it's good now because of NHM having a lot of strategies to follow up the babies. And 24 bar, the monitoring sheet is a very hectic monitoring sheet where ABGs needs to send every 6th hourly and electrolytes needs to send every 12th hourly. So all these things, the only here parent have to run for all these things. So that is a very tough thing. So
the NNF has come out with this facility guidelines for before starting the cooling. So we need to, and they kept it and even for the inclusion criteria also to make it more stricter after that helix trial which has come out. It may be good while you are starting it as a initially when you are starting the cooling, have a checklist that whether we are able to do at least these things. Whoever is there, so what are the monitoring that we have to do it? Maybe initial first 10 cases you can do a little overdoing. Later on, once you get the experience, maybe you can start customizing your own protocol in the cooling and then try to look at it. Again, even the systematic reviews also in the resource limited settings have not told that cooling is too superior to the having not cooling or anything, but supportive care is very important. So concentrate on what Suresh has told you. Concentrate more on the supportive care and then try to introduce the cooling with all these strict guidelines with good facility that you are having it, so that the child will benefit much better. So the last question is that again, like the last panel discussion also, how can we avoid the medical legal suits, especially in the perinatal aspect? This is one of the major concern, and I think most of the times pediatricians and obstetricians will get for the asphyxia only rather than postnatal death. What will happen?
Yeah, I think this is the very important concern whenever there's a baby with who needs sustain or there is birth asphyxia. Worry for the obstetrician as well as the pediatrician is about the medical legal aspect of it. So we can do a few simple things. The first and foremost is ensure that the staff who are attending the delivery, and the frontline staff mainly, should be well versed or trained in doing the at least basic NRP, which is again, as I mentioned in my previous talk about helping babies thing, where they showed that mortality and morbidity both can be reduced by doing basic training in resuscitation. And second is important thing is about documentation. This is something that's going to save us even if it goes to the court of law. So have a good documentation, record the time. Particularly legible writing is very important when we doctors document. Having a good document the time of birth, the APCAR scores, and be specific in the documentation. Don't be objective. Don't say that baby did not cry after birth. Do the basic assessment. What is the heart rate? The baby is breathing or not? So that is very important to do the objective as per the NRP. Just follow the guidelines, and it makes things easy for us. Next is about communication. Again, this is very important. As in the previous talk I was mentioned, communication with the family is very important, whether it be day-to-day routine care or following a resuscitation. If you are communicating well with the family, explaining them the events, don't give false reassurances to the family. Explain what has happened and be honest to the parent that what has happened and how we are going to deal with it. This will reduce the medical legal aspect of the things. Then availability of equipment. Again, when we are talking about resource limited setting, we always think about how the equipment are. Ensure that the basic equipment are at least ready for the resuscitation, and the team has to prepare and check that these things are working when they go for resuscitation, like bag and mask, suction, and a good warmer, and all these things should be ready. And then when the baby needs help, they should be prepared and have at least a clear plan how to refer the baby to a higher center or where the baby could be given a higher care. So, and then having a guidelines, following national guidelines will save us. If you are following the protocol as per the NRP, that will save our skin. And all the staff should have some legal protection to them so that they can be of help when it is needed. So time and again, we may have to face legal suits, so be prepared for that. And last but not least, talking to the family whenever you have time. If you are able to speak to the mother or the family, it will be very helpful. Suppose sometimes we know antenatally that this baby is going to have a problem, whether it be known medical condition or unforeseen conditions. If we have a word with the family whenever you are ending the delivery, if you have time, speak to the family, then the family get to know you and they know what to expect from the delivery. So that will help us. So to sum up things, training of the staff, documentation, and clear communication will reduce our legal risk. Adherence to the guidelines and having a proper referral system will ensure both patient safety and our safety as a staff. And having a proactive approach is what is needed when you are in a resource limited setting. That is when to refer a case. That's it. Thank you.
Basic principles of law also, that whether the person who attended the delivery or post-delivery management is competent or not, that we need to look at it. Whether he has documented what he has done, second thing, and communicated to the people, that's what important. And fourth one is that you need to have some protection. Okay. So these are the things that we need to keep it in mind while we are going for any medical legal suits and everything. So thank you panelists for answering all the questions. We have some 2 minutes time. We can take 1 or 2 questions if anybody has.
I think cooling, everybody talks about it, but we are not able to practically do it. And it's not what you call surprise for a startup. But definitely there is more network happens. So then the cooling will start and begin. We cannot wait for the entire team to come for the cooling to happen. So whatever teams we have to gauge them up, make them start the coolings. If you are not following the entire criteria, at least do the partial and at least add to the data to the research. Then only it will get more and more coolings will happen and the staff will become more confident.
Completely agree with you on that. But we can tell, because this is a legal issue once again, because of the evidence which is available and other things. So maybe we can tell to the parents in the beginning, see, we have these facilities. This is the criteria. Your child is fitting into this criteria. We have the experience to do it. If at all anything problem happens, we will tell you. So being a honest and then open talk at the time before initiating of your cooling will try to save a lot of things, and then you can contribute to the society. So for the sake, both in terms of lives and also to the education and research. That's obviously, I completely agree on this. And you cannot stop also complete cooling at different levels. Any other queries or comments from anybody? Yeah.
So the comment that I'd like to make is, at least for since nurses are here, some junior doctors are there. when it comes to cooling, see, we receive the baby. So we see a baby that has had it's encephalopathic for some reason. It might not be encephalopathic also. So the right terminology to document at that point of time will be just writing newborn encephalopathy. Don't use the word HIE at this point of time. Go evaluate, and evaluation is what you have already discussed here, and then you give a diagnosis finally at the point when we are sure that this is actually a case of HIE. Because HIE, there are definite criteria which is required to be satisfied. There should be a definite intrapartum or a perinatal event that has happened there. A lot of times in India, we don't have perinatal events at all, because perinatal events don't happen in the actual perinatal immediately prior to birth or even before that. There are some remote event which has happened. It could be a genetic reason, it could be a chromosomal anomaly, it could be an infection which has contributed to all this encephalopathy the baby is having. So at this point of time, don't use words which could actually inflame the family also, because that is very important. So that's what I wanted to communicate.
Even the ICD codings also nowadays are saying that only use the term neonatal
Neonatal
encephalopathy
encephalopathy.
and probably of perinatal origin, which we can try to use the ICD code also. That code is also there. So those who are using the coding for the discharge and other things, you can utilize that rather than just labeling it as a HI. That's Thank you, Dr. Giridhar. I think that was well. So we have moved to that now fast for the last 5 years, because otherwise we cannot survive. That's amazing. Okay. You should tell in the beginning only, and even in the discharge summary or in the death summary, you write that it is severe neonatal encephalopathy, probably of a perinatal origin. Don't write again due to birth asphyxia in the
Birth
bracket.
asphyxia has a
So
very
that
negative
wording itself is
effect.
a thought block for many of us, and then it has a lot of taboos on that. That's what it is. Sure. Thank you very much for giving us this opportunity, and then hope you had some good thoughts to go on to home. Thank you.
May I call the moderator and the panelists for a photo? Are there any questions on the online platform? I think we don't have time for that. So I think we'll just take a 5-minute break. I think we're already running behind schedule by around 30 minutes now. So 5-minute break, and we'll actually come up again actually in another 5 minutes time. Thank you.
Attention everyone. So let's come back to the session. Now we have a panel discussion on all about sepsis, and this moderator is Dr. Sridhar Santanam sir. Sorry, senior neonatologist from Velur, and I request sir to please take over the session. So the panelist for this session is Dr. A.S. Kiriti sir. Sir is Vice Principal of SVMC, and Dr. S. Ramprasad sir. Sir is Secretary of NNF AP, and Dr. H.N. Sir is Senior Neonatologist from KIMS Karnool, and Dr. Noris Suryanarayana sir. Sir is Senior Neonatologist from Vijayawada. So today we will be having two launches. One is DigiNNF launch, and also one is all about sepsis launch. And our Dr. Sridhar Santanam sir is the chairperson for all about sepsis committee. So this is a NNF action plan 2025.
Thank you. Good morning. I'm Dr. Sridhar. I'm a neonatologist from CMC Vellore. Actually, today I seem to have a very experienced and very varied group of neonatologists as my panelists. This is a talk on all about sepsis. How do you manage babies with sepsis? All of you are PGs, pediatric PGs, most of you? Okay, sure. Okay, and general practitioners. So the group here, which is very interesting, is that I think Dr. Kiriti and to some extent Dr. Ramprasad manage, Dr. Kiriti almost certainly inborn babies, mostly inborn babies. Dr. Ramprasad, a mixture of inborn and outborn, and Dr. Naveed and Dr. Suryanarayana are mainly outborn babies. So even managing sepsis, there is going to be some difference in what sort of unit you're working in. So we'll sort of try to get overview on what we do with babies with sepsis. So this was something that we did even in the National Neocon. What we did is I was asking all my PGs and all the general pediatricians, what problems do they encounter when they manage a baby with sepsis? And we tried to get a list of questions which were the most confusing or which were, I think. First, before going there, this is one of the most important things. When we suspect about, say, 100 babies to have sepsis, how many babies will actually have sepsis? Can any of the PGs tell me? Newborn, when we manage 100 babies and we think that they have sepsis, so they have fever or they have respiratory distress, and you're starting antibiotics. How many of them will actually have sepsis? Huh? 50, 60, yeah? No, it's not so. It's much less than that. Okay. Even in those babies who you think have sepsis, only about 30% of them will actually grow a blood culture will become positive. Okay. But we are going to cover all these babies with antibiotics, and that has a lot of implications also. So I just wanted to ask, like I said, we have a varied group and it will differ. I just wanted to ask Dr. Kiriti and Dr. Ramprasad, what antibiotics do you use as empiric antibiotics for a baby with suspected early onset sepsis, Dr. Kiriti, and why or how would you choose these empiric antibiotics?
So, hello, am I audible, sir?
Yes.
Yes, thank you, sir. Good morning, everybody. Thank you for the organizer for giving me the chance to participate in the panel discussion. So, as per the early onset septicemia, early onset sepsis is mostly in maternal origin. and that too in where our unit is more in concern on the inborn people for newborns. So my first antibiotic choice maybe which should cover most common organisms, E. coli and all that. My first antibiotic choice is ampicillin with gentamicin. It's a combination of both. It covers both gram positive and gram negative organisms.
So up to 48 hours or 72 hours you give?
Before 72 hours, early onset.
Dr. Ramprasad, anything different?
Yes, sir. Usually, the unit where I work is we have inborn babies, around 100 deliveries we have. So mothers who have fever, chorioamnitis, or mother who have received antibiotic prophylaxis. So these babies we usually start on initially after sending blood culture. We have started on Ampigenta. So both have synergistic action. You know, ampicillin covers gram positive, most common GBS, all these things, and aminoglycosides covers E. coli. So, and both have synergistic action. One ampicillin works on oral cell wall and gentamicin on the main nuclear, this one. So these two have good synergistic action. So these two antibiotics cover most of the gram positive and gram negatives. So we use for around 48 hours since till the blood culture is negative. So if blood culture is negative and child is clinically stable, we'll stop. And those are the routinely used empirical antibiotics in our units.
Dr. Naveed and Dr. Suryanarayana, for a baby with suspected late onset sepsis, so after, you can tell us whether after 40 hours you take it as late onset sepsis or 72 hours, what would you use as an empiric antibiotic and how would you choose your empiric antibiotic for late onset sepsis?
Sir, as you mentioned before, ours is mostly an outbound unit, so we get sicker babies or babies who have already been on some kind of antibiotic before reaching us. Our first line antibiotic, what we have decided is after having our antibiogram. I think that should be done by any unit, have their own antibiogram or sensitivity patterns, and based on that you choose your first line antibiotic. Whether it's first line or second line, for whether it's early or late, we take 72 hours as a cutoff for early and late. We normally start with peptides and gentamicin. Which we decided.
Does that cover about 50 or 70%?
Yeah, generally the first line antibiotic should cover, as we theoretically say, more than 50% of the infections that you see in your unit. So based on that, we chose peptides and genta, and that's what we are using. Like Ram Prasad was saying, doing a blood culture is the most important thing. That's what guides us, and then even to plan a change any antibiotic in future. This would guide us. So blood culture is the most important thing. Do not give any antibiotic without doing blood culture, because some units
That
we see
has to be
do that,
reiterated.
and that
We
should be
found
the
out
priority.
Yeah, there's a thing saying that more than 50% of even SNCUs in India do not do a blood culture before thing. And if you do that, whatever you talk about antimicrobial stewardship, it's not going to happen because you don't have an idea what bacteria you're treating. You're just giving antibiotics. So you're like, Dr. Suryanarayana, anything different, sir?
Yeah. See, when it is, as we see, most of them are outbound, which come to our hospital. And then they're partially, they're all, many of the time partially treated. And then generally we do a blood culture as the baby comes. Then our choice of drug would be peptides with amikacin. That's the combination which we use generally as a first line drug here in this situation.
Fair enough. So I'll just, I don't know if the PGs are aware of this, okay? This is a group of, this is a list which is given by WHO, okay? This is called AWARE classification, AWARE. A stands for access group, WA stands for watch, and RE stands for reserve, okay? Ideally, WHO says that empiric antibiotics, it's nice if they are part of the access group. So you'll notice of the access group, the ones that we use in newborn are amikacin, ampicillin, crystalline penicillin, and gentamicin. Okay, all the others are generally not used in the newborn, right? It is very good to use these because, especially, like I said, there is a difference. If you're a pure inborn unit, like my unit is mostly 90% inborn. If I use anything of the access drug, it is likely that not only will this baby have less late onset sepsis or will be colonized with resistant bacteria, but even your unit will be colonized with less invasive bacteria, okay, less resistant bacteria. The next is the watch group. But like I said, Dr. Suryanarayan and Naveed actually pointed out that theirs is an outbound unit where the babies are already treated with antibiotics. So it's likely that most of the bugs which are colonizing their gut or their skin may be resistant to the ampicillin or gentamicin. So for them, sometimes they go on to the watch group. In the watch group, these are antibiotics that are relatively high risk of selection of bacterial resistance. Here you'll notice all your third generation cephalosporin, your piptas, and your meropenem. So if it's possible in an inborn unit, do not use these drugs as empiric antibiotics, at least for in the first 72 hours. Okay. Outborn unit, unfortunately, sometimes you do not have a choice. You might need to use watch. Do not use your reserve. Reserve is colistin, what you call ceftazidime, avibactam. Okay, all of these things. Right. I just wanted to reiterate. So we'll start off with the actual. Like, Doctor. Dr. Ramprasad, so you have a baby. This is a fairly common thing. Your baby is born at 40 weeks of gestation, and there's born through meconium stained liquor. Baby has respiratory distress, and X-ray it shows non-homogeneous opacity suggestive of MAS. Would you evaluate this baby for sepsis? Would you do a CRP or a PCT, any of your biomarkers for this baby? If so, why? Or why not? And how would you interpret the CRP and PCT? This is a common thing. We have MAS, and there are varied thoughts.
Yes, so it's we all know that meconium is one of the common scenario we see in either each and every hospital. We have seen this one. Definitely, we have to evaluate for sepsis because fetal diarrhea can cause all these things problems. First, fetal hypoxia can cause meconium. So to rule out the cause, definitely X-ray picture and GBS can be same. So definitely we'll evaluate. We'll send the blood culture. We start on antibiotics or meconium aspiration, but CRP procalcitonin. Both are inflammatory markers per se in meconium babies for 12 to 72 hours. CRP procalcitonin as a part of inflammation can go high, not only because of sepsis. So based on CRP procalcitonin, I will not decide which antibiotics to continue or not. I will base most on clinical methods and of course blood culture. If blood culture is sterile, I'll be confident enough to stop on antibiotics. Provided CRP and procalcitonin are minimally raised. The first 40, beyond 40 to 70 hours, it will be raised. Based on those, I will not decide whether to upgrade the antibiotics or not.
Fair. There is a thing to say that meconium is sterile, and we know that meconium is not sterile anyway. So many people used to say that when meconium goes into the lung, there is no real reason to start antibiotics. Matter of fact, the last panel discussion that I did, Dr. Tejo was one of my panelists in Delhi, in Noida. I think 2 of the panelists actually said they would not start antibiotics. I don't have the guts not to start antibiotics for meconium aspiration because one of the things is sometimes fetal diarrhea can also be a stressor which causes the baby to pass meconium. And meconium we know is not sterile. So at least for 48 hours, we do a blood culture. And if the baby has not deteriorated, baby is at the same level of thing, we stop, as Dr. Ramprasad said. So the next thing is to Dr. Naveed. The same baby, you're managing the baby with meconium aspiration syndrome who's on the ventilator. And this baby then after 3 or 4 days sort of deteriorates. And he has features which are suggestive of ventilator-associated pneumonia. And there are increased tracheal secretions. The nurse says that his tube gets blocked very frequently, and she needs to do frequent suctioning. And you change the antibiotics after a blood culture. The first question is, would you send a tracheal aspirate for this baby? And if the aspirate grows Acinetobacter, which is a lung bug, okay, and it's a deadly bug, right? But the blood culture is negative, would you change the management based on that report, even if the baby is improved on your antibiotics, which you have changed empirically?
Okay, sir. The first part of the
you
question.
do in practice and what would be the...
For the first part of the question, we don't routinely send tracheal aspirates, and it's very rare. To be honest, I must say we rarely send any tracheal aspirates. But if you have already sent it, it might help us to know what type of bacteria is in the baby's airway. But we should know that it is only colonization. It does not indicate a sepsis or a bloodborne infection. So it just guides us, or just to keep in the back of the mind.
It can even be contamination of the ET tube, not even a colonizer. It may
yes,
not
sir.
even be
Even the contamination from the ET tube or from the oral cavity. So yeah, just to have at the back of the mind what bug is there in the baby, but not as such in the blood. In the second part of the question, if the baby is improving on our empiric antibiotics and the aspirate has gone Astrobacter, the baby is improving. I mean, There's no point in changing the antibiotics because baby has responded. So we'll continue with the same antibiotics and wouldn't upgrade the antibiotics to cover the Acinetobacter. On the contrary, if the baby deteriorates on our empiric antibiotics and our culture hasn't shown anything, I would use an antibiotic that would give a cover against that Acinetobacter as well, because we know the baby is deteriorating and we know that bug is in the baby's airway.
Fair
Thank you,
enough.
sir.
The general consensus is not do not treat colonizing organisms. So we don't send, like we say very rarely, or I don't remember sending tracheal aspirates, especially newborn. We don't send tracheal aspirates, don't believe umbilical line cultures, okay, things like that, ear swabs, skin swabs, don't treat them, don't think. But like Dr. Naveed was saying, sometimes you have a baby where blood culture is negative, baby is deteriorating rapidly, you have no idea what was the next step. At that point, if the tracheal aspirate shows an organism, you at least know that it's somewhere in the vicinity of the baby's airway. Then you can see whether the organism which covers antibiotic which covers Acinetobacter may help the baby to recover. So that's the only thing where you would probably take this thing. But if the baby is improving, one, try not to do a tracheal aspirate. But if you do it and the baby is improved on the second thing, do not treat the colonizing organism. Dr. Kiriti, this is a very common scenario in the postnatal ward. The registrar in the postnatal ward finds a newborn on day 5 who has multiple pustules but is otherwise well. What should be the best course of management? So would you do a blood culture? Would you give IV antibiotics, oral antibiotics, local antiseptics?
First we had, so because it is a multiple pustules, first we have to count the number of pustules, sir.
Sure.
If it is more than 6, we have to give importance to those people. And less than 6, so we can leave it alone. And if it is more than 6, first we have to send blood culture, and you can start empirical antibiotic. And
would you start oral or IV? Would you start
always IVs. And suppose if pustule size is more than 1 centimeter, then you have to give systemic antibiotic only, sir. There is no role of any oral antibiotic as such, and there is no role of local antiseptics also for this.
Okay. Anybody will do anything differently or in this scenario? Yeah, like Dr. Yes, Dr. Ramprasad.
Basically, you are sure that these multiple pustules are because of sepsis or infection, or sometimes we send transient conditions, transient neonatal pustular melanosis, sometimes can be multiple pustules.
Correct.
But child is clinically stable, and if you feel that there are transient, I may even wait for sending these issues. But if you are confident child is, that's a staph infection, then we may send antibiotic and start an antibiotic.
Yeah, I think.
One more thing I would like to tell here. Any pustules in the genital area, we have to look for any, suspect any fungal infection also sometimes.
Okay, sure. Fair enough, especially if there's erythema and thing. But like Dr. Ramprasad said, and Dr. Kiriti also briefly mentioned, the majority of pustules, there is I think a huge study from France where they looked at the etiology from Belgium. They looked at the etiology of pustules in the newborn, and they found that more than 90% of them were actually non-infective. Okay, so it can be neonatal pustular melanosis, it can be many things. Very surprisingly, few of them only bacterial. In India, it might be slightly different, but still the majority can be non-infective. So wait, and this seems to be more guidelines than anything evidence-based, but generally more than 5 or 6 and a larger size pustule, or if the baby is unwell, then start antibiotics. There are case studies and there are thing of giving oral antibiotics here, also first generation cephalosporin, but many people do send a culture also just to make sure that there is no invasive thing and start IV antibiotics before going on to Dr. Surya Narayana. This is something I was telling you. When do you consider a newborn to have meningitis? And please give objective criteria. This is because we get a lot of referrals. I've seen babies who have been started and given antibiotics for 3 weeks based on neurosonogram evidence of meningitis. And I have no idea what indicates meningitis in a neurosonogram. We've had babies whose total cell count was 0, but just because the protein level was more than 100, the babies have been on 3 weeks antibiotics. So there are various reasons why babies are given prolonged antibiotics for meningitis. And this is one of the not gray areas, this is a very thin area. So I wanted Dr. Surya Narayana to sort of clarify when exactly would you call a baby to have meningitis?
So every case of in newborn, whenever you think of sepsis and culture is positive, there is a definite indication for doing a lumbar puncture, and then after lumbar puncture is the gold standard way of diagnosing meningitis. So the things we usually do when we do a lumbar puncture is send a CSF for culture to examine the CSF for sugar, cell count, and protein. So a general guideline is, of all the things, sugar has got the least importance or the least effect, whereas protein and cells have given greater importance. A CSF cell count of more than 20 is usually considered to be that the baby has got meningitis, and a protein range is usually between 120 to 150 is also considered to be above 100 is generally taken to be positive for meningitis. And sugar, as I said, has got one of the least importance of all the three things.
Dr. Suryanarayana was saying that he works in an outborn unit. So generally babies have received antibiotics and he's almost never seen a baby with a positive CSF culture, isn't it? Yeah. Huh?
Yeah, we do see definitely.
Okay, okay. Almost never, or very rarely. Okay, so that's one of the things. The gold standard will be if the CSF culture is positive, but the general rule of the thumb or thing is that by about 6 to 8 hours of starting antibiotics, gram-positive bacteria, your culture is going to become sterile, and by 24 hours or 48 hours, gram-negative bacteria. But then rarely you have Citrobacter and Klebsiella and all that, even after prolonged antibiotics, they are positive, but it's very rare for the cultures to be positive. So then if the baby has received antibiotics, the CSF cell count is the most reliable to diagnose meningitis. And as sir said, anything more than 20 is generally supposed to be the most reliable thing to say meningitis, followed by protein.
Would you send CSF PCR also, sir? CSF PCR.
CSF PCR. PCR is a slightly thing. Yeah, maybe you can use it. Yeah, PCR. Sorry.
Yeah, definitely. We have tried this because many of times there is a situations where cultures are going to be negative, and we have tried enough number of cases CSF PCR, and in certain situations it looked, but it is little confusing because sometimes you get two organisms positivity. That is one of the most difficult thing to make a decision in such situations. When you get a single organism are not detected, still it is fine. When you get two organisms in a CSF PCR, then we get into, and one of them turns out to be fungal, it is much more difficult.
We did the ANISA study. I don't know if you all remember the ANISA study. That was a Bill and Melinda Gates study in India, Bangladesh, and Pakistan, where they did even blood PCR versus culture. And the blood used to grow about 8 organisms. It was done in the community. Okay, so PCR, that is the problem. So even if a small piece of DNA is there, it will think. CSF, I do not know because it's supposed to be more sterile, how much it will grow. But at the moment, I don't think CSF PCR. Dr. Naveed?
Sir, if you're suspecting any herpes infection, we generally
viral infections, PCR, definitely. Viral infections. Yeah, Streptococcus pneumonia, yeah, very unlikely in things. Streptococcus also latex agglutination and PCR are one of the things. But yeah, yes, you can. Right. Dr. Kiriti, you are evaluating a baby with suspected sepsis on day 5 of life and you start empiric antibiotics. The counts are normal. The baby improves by 48 hours. Blood culture is negative, but your CRP is 50. And your thing. How long will you give antibiotics for this baby? What is the evidence? What do you do in your practice? And does this work for you?
Okay, sir.
This is a very common scenario,
yes.
right? Where your blood culture is negative, baby seems to have become all right, but you do a CRP because the baby was initially
child is clinically improving and
has normalized.
Improving.
Yes, improving.
Clinical suspicion of anything, but clinically improving, but CRP is 50, CRP positive, but culture is negative. So in such a cases, whenever the CRP is 50, so we cannot abruptly stop the antibiotics. We can continue for 5 to 7 days only, not more than beyond 7 days. And we have to reassess the child. If child is deteriorating, depending upon the situation, we can continue antibiotic or not. Otherwise, if child is improving after 48 hours, and even though it is CRP 50, we can give up to 7 days only, 5 to 7 days.
I think the current NNF thing still says that, and even IPM is at least 5 to 7 days when CRP is positive. I think again the Delhi group is doing a thing on stopping antibiotics based on your blood culture in spite of CRP being positive, but the results haven't at least come out. It's likely that we might get something more information, but as things stand, when the CRP is positive, either if it's very positive until it becomes negative, or at least 5 to 7 days you need to give antibiotics if the baby was initially symptomatic, right? So Dr. Ram Prasad, this is a baby who's, just assume that it's the same baby who was symptomatic, okay? And this baby has grown E. coli, which was being treated with appropriate antibiotics. You can see that it's susceptible to amikacin, nettlemycin, piptaz. So just say piptaz, amikacin. How long do you treat culture positive sepsis, and what is the current evidence on treatment of culture positive sepsis duration?
Classically, as of now, what we are treating is for blood culture positive gram-negative E. coli. We give for only blood culture without meningitis, we give for 14 days. And with meningitis, we give for 21 days. And of course, the complications may extend also 8 weeks, ventriculitis, all these things. But as you said, sir, there are studies are going on. Still, Delhi group study is staying. So they are stopping, even though blood culture is positive, they are trying to stop around 5 to 7 days, I suppose. So still, as of now, because we don't have clear-cut consensus on that one, because gram-negative causes loss of devastating effects. So we continue for culture positive 14 days and meningitis 21 days. That's what we are following, sir, as of now.
Yeah, I think again, Dr. Suryanarayan also was telling about some studies and.
I strongly agree with what he's saying. As far as present evidence, we are going to that. All culture positive thing, we give 14 days and
for gram negative.
For gram negative. For meningitis, 21 days.
Gram negative, we generally give for 7 days and stop if the baby is clinically improved and inflammatory markers are normal.
Okay.
We are stopping at 7 days.
Okay.
So we've not found any.
Do you follow up those babies at CU?
Yes, yes, they are okay.
Okay. I think again the Delhi group is doing a thing on 7 days versus 14 days now. I think it's ongoing or nearly finished, but still we are not getting. So last year, so they were doing a study. There was only one study from PGI Chandigarh on 5 to 7. Yeah, 2 studies. That was short duration versus standard duration. I think they found that only in Staph aureus sepsis, the babies deteriorated on 5 to 7 days antibiotics. All the other ones, 5 to 7 days of antibiotics if the baby was clinically well by
Staph aureus 14 days.
Okay.
14 days because risk of abscess and
again, all of them, yeah, they were very small. So I think this study by the Delhi group is actually fairly big. It's an ICMR study. Hopefully, it will give us better answers. And you were mentioning that anyway, your what do you call ventriculitis and bone and joint infections, that is a different ball game altogether. If the babies do have that, then you're going to extend your antibiotic duration. Which babies? One of the things I will just come to one more. I don't know if that thing got. No. So one. Right. Can we just answer your question after this question? Right. So I'll ask Dr. Naveed, under what circumstances will you not treat a baby's positive blood culture? That means your blood culture shows some organism, but you consider it as a false positive blood culture. In short, which organisms will you consider as contaminants, or which reports will you not treat?
So, one, if the organism that has grown is a general commensal that we know, like a coagulase negative staph, and at the same time, baby is clinically well.
Staph will be a conditional contaminant, isn't it?
Yes,
sometimes you will treat,
yes,
sometimes.
sir. Yeah, that's what I'm. And if the baby is well,
Dr. Suryanarayan was saying Burkholderia cepaceae also. Sometimes it's or many times it's a contaminant. Sometimes it's
Burkholderia, which and if the baby is clinically well, when we generally are, if you have done a blood culture, we are doing inflammatory markers as well. If these are normal, baby is clinically well, and if it has grown common commensal that we come across, then we wouldn't treat.
Can you just name so that PGs, there are many PGs
coagulase negative staphylococcus, some of the Pseudomonas cruzi that you were saying, because it, as soon as you see Pseudomonas, you think it is a serious infection, but that is one of the skin commensal. Some of the bacillus group of organisms that are common commensals. So such organisms, and then the criteria is the baby should be well, and if it is not an ESBL kind of baby who has a central line PIC line in situ, all such babies, and again if you have grown a polygrowth, multigrowth, then you generally repeat a blood culture and see what comes out in the next time. at the same time continue the antibiotics, unless if it is a gut infection where you can have multi-growth from the blood cultures, like you can grow enterococcus organisms and Klebsiellas. So if it's a gut infection, that's one thing. Or if it's a delayed growth is the last thing, sir. If the blood culture is a scanty growth, if you are doing your bacterial cultures, if the culture has grown after 3 days and if it's a scanty growth, we generally ignore it. Again, provided the baby is well, that's the first priority. If the baby is well and such organisms are growing, you would generally not treat such babies.
Dr. Suryanarayana was giving me a big list of contaminants this morning. So you can, I think, repeat the other things.
We usually micrococci can be some of them.
Correct.
That micrococci can be there. Bacillus, cornybacterium can be this, and our coagulase negatives, which can be sometimes pathogenic, sometimes usually can be commensal. Improper preparation of the site when taking blood cultures, they all contribute to this positive blood cultures instead of child being active and fine.
Yeah, that's true. So for the PGs, when you see aerococci, micrococci, okay, what you call Corynebacterium species, okay, Bacillus species, they are all definitely contaminants. Recently, we had this thing of Pseudomonas stutzeri in the last 2 years. That's a non-human pathogen. So everybody gets very excited when they see Pseudomonas, but it's not to be treated. Same thing with Acinetobacter L. wolfii. It occasionally causes in geriatric age group UTI, doesn't cause disease in the newborn, so we don't treat it. Burkholderia and cons as conditional contaminants. Okay, polymicrobial growth, we usually take it as a contaminant, and if there is late growth of organism. Coming to Dr. Satish Billa's thing. So generally, one of the things I encourage people is that if you get an organism which is definitely pathogenic in a blood culture, do not do a CRP because it sometimes confuses your thinking. We had one instance where a baby grew E. coli, and I think along with the blood culture itself, they'd done a CRP. Baby grew E. coli, the CRP was negative, and so somebody in their wisdom decided that they will stop antibiotics. Baby had a seizure within 24 hours, okay, and baby became sick. So I was saying, why do you do a CRP? So in a definite sepsis, do not do a CRP. It's just going to confuse your thinking. Unless the baby is deteriorating or not improving as you would expect this baby to. So after 10 days, 14 days before you stop antibiotics, if you feel that the baby is still symptomatic, then do a CRP to see whether there's another infection or the infection is not thing. We'll come to that also. Repeated cultures being positive. Dr. Tejo had some experience with that. Neopins, you're saying? Neopins, yeah. No. He's talking about when blood cultures. No CR.
Yeah, majority of them. So they will end up doing CRP just to see, just to make sure their hearts feel bit better. Okay. All right. So the CRP trend is coming down. They are okay with that. In case I have seen few cases, it's not every day. I am not a CRP promoter either. So the CRP at the end of the treatment, 2 weeks, because we have seen it. So because the baby has a long line in, so they do a CRP and that CRP is still there. So we decided 14 days. Okay, let's give another few more days to bring it down. You see what I mean? These kind of things are just happening now and then more.
Generally, there is a thing that CRP reduces your duration of antibiotics. But if you actually look at it, CRP increases your duration of antibiotics.
Yes.
Okay. So you will do a blood culture where normally you would stop antibiotics at 72 hours. CRP will be 10.8 and your cutoff is 10. So that's all. You don't have the guts to stop your antibiotics.
Yes.
You'll repeat a CRP after 3 days, right? So you continue antibiotics for thing. That's the thing dangerous.
Yes, it's not the dictum, but obviously there is a one test which people try and rely on rather than their clinical skills. But nobody will be brave enough to stop when it is high.
In such scenarios, definitely some localization of the
Yes, sir.
sepsis.
Lung line is
one.
insensitive.
Either some
Localized
sepsis,
infection.
some localization.
Inflammation will be there, definitely.
Abscess.
Either developing abscess somewhere else, or developing osteomyelitis.
Yes.
Or some of
Those will be
reasons which,
differentials. Exactly.
when persistent high CRP, you have to definitely look for these things either do a
That's what we do, sir. Take out the long line, give sometimes peripheral.
CRP of 10-20 is okay. If the CRP comes back 100, then obviously, like sir was saying,
There
look for
might be
any
a-
localized
that
infection,
can-
abscess formation anywhere. And
Not only that, a baby with sepsis can have another infection also,
Yes, sir.
because this baby is more thick. Dr. Suryanarayana, one thing is you have this culture report for a baby. This has grown Klebsiella with this sensitivity pattern. Okay, so two things I want you to highlight to the PGs. One, when would you consider this Klebsiella to be an ESBL producing organism, extended spectrum beta lactamase producing organism? And how do you treat an extended ESBL producing Klebsiella? What would be the drug of choice? Here it's obviously written there ESBL positive, but many of your labs will not write that. So if you can explain to the PGs.
We consider ESBL producing when they are resistant, when the organism is resistant to cefpodoxime, ceftriaxone, or cefotaxime. When such scenario, we consider this bacteria to be ESBL producing.
Yeah.
So when it is an ESBL producing bacteria, then definitely you have to rely on carbapenems as an important line of drugs.
Simple thing. So he's made it very simple. So the usual thing is if it is resistant to any of your third generation cephalosporin, primarily previously it was only cefpodoxime, but now the current CLSI guidelines say ceftriaxone, cefotaxime, or cefpodoxime resistant. It's an ESBL producing organism. ESBL producing Enterobacteriaceae, Klebsiella E. coli Enterobacter. Your drug of choice is going to be carbapenem, imipenem, or meropenem. So that's very succinct and very clear thing. So you have another baby with a Klebsiella infection. You can see resistant to everything. So this question is to Dr. Ram Prasad. So when do you consider, when do you consider this Klebsiella to be, or how do you say based on the sensitivity pattern that it is a carbapenemase producing organism or carbapenem resistant organism? And what would be the drug of choice for carbapenem resistant Enterobacteriaceae infection? Klebsiella, Enterobacter cereaceae, E. coli.
So multi-drug resistant very commonly seen nowadays because of this one. So if they are in this culture, if you see resistant to meropenem or ertapenem, carbapenem resistant group enterobacterials, what we call. So it's very difficult scenario to treat these babies. Imipenem, meropenem, all are resistant there. So here we can treat these babies. We have newer drugs to treat this one. But we definitely require sensitivity pattern for that one. And if you have meropenem, where we see MIC levels less than 8, usually less, you can continue long infusion, meropenem infusions. Usually we can keep for 1 hour, but here we keep for 4 hours infusion with adding aminoglycosides or colistin group of organisms. Colistin antibiotic, meropenem and colistin, if they are sensitive, it can be given. Or sometimes if it is resistant to meropenem and not working, your CRP is going, your baby is not improving, you can add colistin and tetracycline is one, this one. And if they are response to beta lactamase group, they are sensitive to this beta lactamase newer generation of antibiotics, ceftazidime plus avibactam. They are new group of antibiotics, but the thing is, as we are discussing, they are usually 3 genes of these resistant genes. One is in India, it's more of OXA-A4 and metallo-beta lactamases. So these 2 genes doesn't work for the ceftazidime avibactam doesn't work with these 2 group of resistant genes. And in most of the Western countries, they have a resistance to this KPC gene, where the ceftazidime avibactam is a drug of choice there. For here, long infusion of meropenem with colistin and or colistin tetracycline, or sometimes ceftazidime avibactam, we can. These are the drugs we have.
Aztreonum. So the thing is,
With
MBM,
aztreonum.
one of the things when it's, say in India, the thing is the genes that produce carbapenem resistant are primarily in the Western world is KPC, Klebsiella pneumoniae carbapenemase. In India, it's predominantly NDM1, New Delhi metallo-beta lactamase, and OXA48 or OXA48-like. Both OXA48-like and your NDM or WIM or IMP, all will be resistant to avibactam. Abroad, the thing is that was specified that drug ceftazidime avibactam was for KPC producing organisms. 98% of isolates in India are not KPC producing. So ceftazidime avibactam will not work there. Okay, so do not use ceftazidime avibactam as an empiric antibiotic or as an antibiotic primarily. You can use Astrionum will work in MBM. Okay, so you can use either Astrionum. We'll come to that. Astrionum, like Dr. Ram Prasad was saying, ceftazidime avibactam with Astrionum, or extended spectrum meropenem with Astrionum, or colistin with Astrionum, or tigecycline may be a better choice there. The same thing with slightly different organism, Dr. Surya Narayana. No, sorry, this is Dr. Kiriti. You have a baby who's been ventilated and has grown Acinetobacter, which again is resistant to meropenem, imipenem, etc. Everything. So this is carbapenem resistant Acinetobacter, CRAB. Okay, how do you treat this? This is a very highly
dangerous drug,
dangerous
dangerous
infection. High mortality,
Yes.
right?
Yes,
More
sir.
than 50% of babies are going to die. How do you treat CRAB?
So here all are resistant, sir, but only option we left over is a polymyxin, a colistin and a polymyxin B. We can use it, but isolated polymyxin should not give. Always with meropenem, better to give with meropenem. Even though meropenem is resistant, we can extended infusions. We can give it along with meropenem only. We have to give.
Okay. So anybody else anything different?
This is one situation where a single drug like sulbactam can be useful. This is the only situation where sulbactam as a single drug can be useful in such situations.
I'll change the thing slightly, sir. What sir says is correct. Sulbactam here, sulbactam is usually a beta-lactamase inhibitor. It's added to an antibiotic. But for carbapenem resistant Acinetobacter, it actually acts as an antibiotic. Okay, because it saturates what is called as the penicillin binding protein 2 of the Acinetobacter. So sulbactam is a drug which actually hits the carbapenem resistant Acinetobacter. What we have now, we have Acinetobacter, we have sulbactam in India. Otherwise, you can use cefoperazone sulbactam for the reason of getting the sulbactam. But for carbapenem resistant Acinetobacter, the rule is always 2 drugs have to be used. So you have to add it to either colistin or to extended infusion meropenem or whatever it is, or as you say, thing. In India, there have been
ampicillin with the sulbactam.
Yes,
Yes.
ampicillin sulbactam or sulbactam alone or cefoperazone sulbactam with something else you can use.
That be sufficient in terms of the sulbactam dosage?
Sorry?
For it to
No,
bring, yeah.
No, so that's the thing. Now you
That's
have
the trouble.
sulbactam alone.
Yes,
Okay,
that's
so
the
it's better to use isolated sulbactam alone with
Because
another.
combination, you will end up having more of that other
You'll
thing
have
rather
more of
than-
cefoperazone,
Yes.
and you'll have unnecessary exposure to the
Yes,
cefoperazone,
absolutely.
a higher dose of cefoperazone.
So it's
Or
not
a-
ideal.
No, it's
but
not.
We
ideal.
don't have.
Not ideal. Now that's what, like I said, in the last 6 months to 1 year, you have you have sulbactam alone, which is there in India. So you can use sulbactam with colistin or with extended infusion.
Okay, okay. Thank you.
So, Dr. Surya Narayana, you send a blood culture for a baby with NEC, and the following is the blood culture report. This is the thing. So this baby has grown Enterococcus faecium, E. coli, and Klebsiella. And we mentioned previously that polymicrobial growth is slightly dicey. You do not know whether to think.
So when
So
we send
again, will you treat this polymicrobial culture? What is the
Yeah.
evidence regarding treatment of polymicrobial culture?
So in this scenario, this polymicrobial code, we have to believe this polymicrobial growth. And this is one situation where polymicrobial growth is expected. In NEC, there is a mucosal breach of the mucosal barrier. So when this happens, you can have different species of bacteria which are in the blood, which are in the gut, can be present in the blood. So you can grow two or three different organisms. So this culture has to be taken seriously and it has to be treated according to the culture report.
That's one of the things for polymicrobial growth. One rule is that if there is a GI pathology, because for example, your jejunum, you have Candida, you have Enterococcus, you have Enterobacteriaceae. So if it perforates, all these three can come into the blood. Okay, there you have to take polymicrobial growth to be significant. Generally, Enterobacteriaceae, group B Streptococcus, and fungus, they say even if it occurs in a polymicrobial growth, better to treat it. Okay, otherwise it's a slightly dicey. Last, I think we may not have time. I think we have run out of time. So we'll sort of stop with this. Dr. Naveed, this ELBW baby grew Citrobacter in the blood, okay? And this has the susceptibility, it's susceptible to almost all, antibiotics, right? Is there any specific precaution you take while treating this infection?
So one thing about Citrobacter, one regarding the investigations, because it is neuroinvasive, you would definitely do a lumbar puncture and also look for any abscess. So neurosonogram is a must for all these babies. Coming to the antibiotic, as the antibiogram suggested, it is sensitive to all the antibiotics, but still, as we know, it's AMC producing organism, which means it is likely to develop resistance during the course of treatment. So you would generally go with carbapenems like meropenem instead of the usual peptides.
Yeah, just remember this. Citrobacter is one of those bacteria which produces this enzyme. This is an ESBL enzyme, which is class C enzyme, which is called AMP-C. AMP-C, what happens is this enzyme is produced while on treatment with antibiotics. So on the 4th or 5th day of treatment, the resistance starts. So, and that is actually induced by your, obviously it's an ESBL, by penicillins and cephalosporins. Okay. So one rule while treating Citrobacter is try not to use piperacillin, tazobactam, or third generation cephalosporins. Better to use carbapenems. I think we'll stop with that. So this is generally what they said just now for ESBL enterobacteriaceae. Preferred drug will be meropenem or imipenem cilastatin. Do not use piptas or third generation cephalosporins. For AMC producing organisms, use carbapenem or cefepime. Do not use piptas or third generation cephalosporin. For carbapenem resistant enterobacteriaceae if susceptible, meropenem, imipenem, ceftazidime, avibactam if susceptible, otherwise of any of these, right? And if MIC is so much, use extended infusion meropenem with colistin or amikacin. And for carbapenem resistant acinetobacter, use sulbactam with extended infusion meropenem or sulbactam with colistin. I think we will stop with that. We do not have time. We have exceeded our time. So thank you very much to all my panelists. It was a wonderful thing. I'm not sure we have time for questions also. So I'll stop. Thank you.
Moving on, next we'll go to the panel discussion on less is more, the management of respiratory distress in preterm infants. And to start the proceedings, I would like to invite our moderator, Dr. Nalinikanta Panigrahi. And the panelists in this session is going to be, one of the panelists is myself, then Dr. Venkata Suresh, and Dr. Murali Raj will be joining us.
So good afternoon to everyone. And before the session, start of the session, I appreciate the previous panel. Actually, it was enlightening and learning for us also when we were listening, because that's one of the commonest things, sepsis. And after that, again, we are going to, this panel, we are going to cover another common, very common NICU entity. There's a preterm RDS babies case scenario and its optimization of the management, how to manage a preterm RDS scenario. To continue this, already my esteemed panelists all joined here. I probably no need of an introduction to individual basis, but still, when the presentation, ongoing presentation is happening, I will just request all the please go through the questions and enlighten us. It is not some viable question that we are going to, I am going to ask the questions. In the, as for the, when the case discussion is happening, you, whatever the inputs about the case and how we can best manage, you can contribute for the others also. A question comes to one of the panelists, others can contribute. Before coming to this presentation, before going to the management here, the title here, theme given today is a preterm baby's distress management, less is more. Less is more, how to define less is more? One baby is less, maybe more for other. Babies, if you are 24 weeks, we are speaking 26-week babies, what we are doing, maybe more for a 32-weeker baby. But both are preterm. But for 32-weeker babies, what we are doing, very, very less for a 24-weeker baby. So very difficult to define, less is more. So the less aggressive, more words to be avoided in neonatology, always to think how to optimize the care. Optimize an individualistic approach and personalized care should be there. So to continue that, I will invite all the panelists, Dr. Giridhar, Dr. Murli Raj, Dr. Padmini Priya, and Dr. Venkat Suresh. They are here already joined us to continue the discussion. Before again going to the case discussion, which is a very, very simple case, I will give a real case example scenario during our postgraduate days. You have seen many of the surgical management. The first line of management, what the book writes many times, masterly inactivity. The less is more is typical example happens something if you understand poorly. Masterly inactivity. What happened? 3 o'clock early morning, a 6-year kid came with appendicitis. The postgraduate student admitted with IV fluid antibiotic, left and slept somewhere. Next morning, when the discussion happened with a guarding abdomen with perforation, what the answer was there? The first line of management of a stable baby is masterly inactivity. So what the professor asked him, masterly inactivity, who can do? Who is a master on the subject and the clinical, if you are clinically achieved a master of observation skill and you can monitor the baby, then the word probably applies there. Not that not doing anything is not your goal. For same thing, before going the theme, I will say less is more means not doing anything is not less. Doing the right thing, doing the optimum thing is the less. Maybe more times we do in neonatology, but we will try to see how through the case discussion, how we'll go the best possible way with optimum treatment, how we can proceed. The case is very simple, 29-weeker baby, boy baby born with 1100 grams, admitted to the NICU because after delivery, normal delivery, there was no distress. But the history here says no resuscitation required. When the history, no antenatal steroid covered to the mother. And we don't know specific maternal histories here. With that, the baby admitted into NICU. What happened exactly? There is a typical prototype case we do in the ventilation workshop. 2 hours after the mild distress happened, the pediatric register who is there, they assess the mild retraction, no grunt. So they know no grunt means no severity. Started on hood box oxygen and the saturation was reached to 92%. Did ABG quickly because the guidelines says the preterm babies, if RDS within 1 hour, try to do ABG. So the ABG is looking reasonably stable, 7.30 pH, 55 PCO2, 38 PO2, because this is not a arterial ABG, this is a venous blood gas. So the PO2 is 38 with saturation 92. Chest checks are done. Chest checks are not obviously any clear indication of any severe radiological abnormality of any RDS symptom here. Slowly what happened is the X-ray is normal, ABG is normal, and on hood box oxygen somebody put in the ICU. What happened within 6 hours? The baby's respiratory distress increased, was required ventilation within 6 hours of life. Further deteriorated over next 2 to 3 days, baby required ventilation, baby required surfactant. So initial setting of ventilation 20/5, 60% FID requirement was there, rate 50 managed. Baby settled over 3 days, 3 to 4 days. But what are the course happened in the 35 days? 35 days, baby, 29-weeker baby discharged in 35 days. So exactly 34 weeks PMA, the baby is discharged. But what happened to the baby? The baby developed sepsis episodes, which is very, very common. We see in the preterm population, 30 to 40% babies, outborn, inborn, they develop in the course of suspected sepsis or culture-proven sepsis happens. This is a culture negative sepsis happened to the baby throughout the course. One incidence of we can see there is a pneumothorax happened here on the 3rd days of life because the ventilation started late and baby required ventilation and surfactant later. So you can see the pneumothorax happened. Ventilation required for longer days, up to 10 days, and RDS symptom continued up to 10 to 12 days. After that, the baby recovered. But these babies, are you happy? As an audience, when you're listening about the baby when discharged home, are you happy as the baby's management? We'll come to the panelists, they're expert, they'll guide you. But are you happy with the baby's overall? 35 days baby discharged. But are you happy with the outcome of the baby? The way managed? So how many of you are happy with the management? Because baby went home safely. How many of you are happy? No, nobody is happy. So all are unhappy that this is not managed well. So to guide us, we will see that this is the disease, the preterm baby's pathology started before. One of the panelists, Dr. Padmini Priya, I will invite to guide us. This babies, what best we can do. The baby is not born, the pathology yet to evolve. When the pathology started in utero, what best we can do for the baby?
So first of all, let me introduce myself. I'm Dr. B. Padmini Priya. Thank you for the organizers to giving me this opportunity. So as I was clearly telling that, first of all, the preterm, prematurity itself, we will be thinking that as a pediatrician and neonatologist, prevention should be better. We have to be prepared for any preterm delivery. So the management of a preterm delivery or preterm birth starts from the antenatal period itself. So here, as the sir is projecting that usage of progesterone along with the cervical circulage, which are a part of ops category. Here we are concentrated about the things that we, as a pediatrician, we have to do. That is giving the antenatal steroids. There are many studies showing evidence that giving antenatal steroids have a major outcome on the perinatal deaths, neonatal deaths, and also the morbidity such as RDS, intraventricular hemorrhage, NEC, and need for the mechanical ventilation. Where in this case scenario, there is no history of any antenatal steroids, which led to a stormy course in the postnatal period in this baby. So regarding a few words about the administration of antenatal steroids. So recently, all over the country, we are following the WHO's GDC guidelines and also the ACOG 2017 guidelines. So here they recommend that the antenatal steroid should be given from 24 to 34 weeks of gestation, but there are some variations whether to give in less than 24 weeks or beyond 35 weeks. But usually we will be considering giving the dose of steroid beyond 35 weeks also. It depends on the clinical scenario, where the mother is presenting and also the situations. And here WHO advises her to use the dexamethasone instead of betamethasone, as it is not freely available in our country. And one of the important things is it is costly, and also it has to be imported from other countries, which is not possible in our setup. So DEXA is the preferred one as per the WHO. And regarding the repeat doses are recommended. Repeat doses are recommended. The thing is, the first short dose should be given in less than 34 weeks, and there is a time for the birth. And after 2 weeks, if there is a time for risk of getting preterm death, we can repeat the dose of giving the dexamethasone. So 2 doses as per the all guidelines are recommending. So we can give the repeat dose of the antenatal steroids for this. So my advice is here the mother, the antenatal obstetrician should have advised about the antenatal steroids and should have been given the steroids even though if she is going into labor. Because within 24 hours, if we give a steroids, there is some role. Even though the long-term outcome is not there, but still we can reduce the respiratory morbidity in such children. So it can be advised even though if the mother is coming in the labor pains, whenever coming to her labor room. Thank you.
So Dr. Padmanpriya highlighted all the protocols for the recommendation. I will just invite Dr. Giridhar. This is the golden bullet of neonatology.
Yeah, say
Neonatology, nothing works in later, but one thing which absolutely can work and save the baby's life, preterm babies, that's the antenatal steroid. So few of from your vast experience of so many years, few of the practice points was the audience should learn today. What are the practice point which specific to India we can apply?
Yeah, so the practice points specific to India are now, I think obstetricians are well aware that steroids will be of benefit to the newborns in terms of reducing both mortality and then various newborn morbidities. Now they are overdoing. So the problem is that rate preterm population where international guideline is there, which says that it can be considered, and but there is a WHO guideline which says should not be done. And our NHM also says that it should not be done beyond 34 weeks. So that is the reason we had that action trial, which actually looked at whether the antenatal steroids work in this population of 34 to 37 weeks of gestation. That's a late preterm population, where it has been clearly seen that, but with the event rate in that particular trial, the number of babies who actually landed up with RDS was extremely less. They could not come to a conclusion. But this is the population which is the maximally represented preterm population. So if you are going to take 100 babies born preterm, around 80% of the babies are going to be late preterms. And the mothers are unnecessarily getting exposed to antenatal steroids. And these are not without any problems in the babies. And the studies are clearly coming up in the last few years. These are follow-up studies of babies who have received antenatal steroids in the perinatal period. And what happened to them in adulthood, they are clearly, and during infancy and pediatric and adulthood, there's clear evidence which says that the behavioral problems, neurocognitive problems are increasing in these babies. So for at least for the clinicians who are in this auditorium, the take-home message is, if there is a call from your obstetrician asking that The mother is a GDM mother. We are planning to electively terminate at 36 weeks. Can the baby receive a course of antenatal steroids? Put your foot down and stay that it should not be given. Okay, that is something that is not recommended. One more thing is the caveat from WHO was don't use in mothers who have had chorioamnionitis. But as we know, chorioamnionitis is a very broad terminology. We cannot define the intraamniotic infection per se because most of us rely on only maternal fever and some surrogate data like your counts, your being high. So that population WHO advises against, but it depends on is context specific. If your hospital can deal with these babies who could potentially have a neonatal pneumonia masquerading as RDS, then I think you can go ahead and ask them to give, provided that mother can be managed and the baby can also be managed. So these are some of the practical points. Of course, DEXA is what we are using, even though beta is available, because the twin salt in beta is not available, which has to be there. So the half-life of beta is not going to be 24 hours. It's going to be 12 hours or even less than that. We don't know. So that is why we advise using the dexamethasone, which is the 12-thalli based protocol, which will be apt for our population. So other than that, now lot of other, neonatologists who are there in various centers who have level 3 NICUs, they are managing this peri-viable units also. And again, there is a call from obstetrician asking whether we have to give antenatal steroids in this age group. So it is again a joint consultation with the family and the obstetric team and the perinatal team. If you are planning to give active management, it is still worthwhile to consider giving antenatal steroids in this population.
Very valid point, because the studies what Dr. Giridhar was highlighting, if one example, I believe 32 weeks you have given, 31 weeks you have given, the delivery happens in 35 weeks. They're causing more harm rather than benefits. That's the point. 34 weeks after two, you are not supposed to advise, but somebody has advised at 32 weeks. The anticipated preterm delivery did not happen. Delivery happened after 35 weeks or 37 weeks. That's the adverse, all the adverse effects, neurobehavior, autism, and motor developmental delay happens in the babies. So how we should be careful equally that we can give up to 34 weeks, but whenever there is anticipated delivery by 34 weeks, if you're missing the upper limit 34 weeks after delivery, no benefit, harm is more. But equally he highlighted peri-viable 23 weeks, 24 weeks. When the extreme prematurity, even exposure of 6 hours of steroid is going to be benefit for the baby. Smaller the baby, higher the benefits. A baby comes 24 weeks, 25 weeks, 26 weeks. Somebody is asking, there is no opportunity 6 hours after delivery will happen. Should I give steroid or not? Give steroid. Because the newer study, the 2025 study in JAMA, what this says, exposure for 6 hours, means first dose, you did not get opportunity for second dose, third dose, or fourth dose dexamethasone, baby delivered. Still there is a benefit. So equally, both extremes we should be careful, but these are the messages that it is needed to be given with caveats and with caution. So coming to next practice, I will come to Dr. Suresh Venkatesh. So after this, one of the antenatal practice very well studied and very well, we are convinced that steroid required for preterm population 24 to 34. Next to that, what best we can do before the baby's delivery, if the baby is coming to our unit, tertiary level unit, what best we can do for the mother or the babies as a diet, what we can do, that's, can you come to that, which can be benefit for the baby's overall outcome later?
Yes, sir. It is a safe transport of the baby in utero. Even WHO advises any mother in impending preterm labor before 30 weeks. So in utero transport is the best mode of transport, where baby is in a safe place, where we don't need any transport incubator or any trained personnel to transport the baby, which will be difficult in arranging after the delivery. So this is the research showing. All the studies in babies who transported in utero, they have better short-term as well as long-term neurodevelopmental outcomes. So in utero transport is the best mode of transport if the anticipated preterm delivery is there before 30 weeks. And for this, we need a coordination between the OG team as well as the neonatology team.
That's right. Absolutely agree, because a baby who less than 30 weeks or specifically or 32 weeks or less than 1.5 kilo, baby delivered somewhere and transported, the baby's IVH chances, infection risk later, or the morbidities in the hospital might be a little bit higher, specifically related to ROP and IVH. A baby who inborn delivery, receiving all tertiary level care from the minute one, golden minutes or golden hours, maybe the best possible way we can treat the baby. So if these two things we can do, steroid to the mother, if the baby, mother referred, and referring the mother rather than delivering the baby and referring to a center later. These two things can prevent the so many morbidities of the babies. So coming to next question, I will ask Dr. Murli Raj. This baby born now, the baby have no distress at all. 29 weeks, 1100 grams. They did not do anything, just shifted the baby to the NICU. But if we are there, a neonatologist team is there available in perinatal center. We attended a baby who is 1100 gram or 29 weeks. What best we can do for the baby in the golden hour management or delivery room? How to optimize, and how should be our intervention should not cause any harm. As by basic policy, do no harm in the baby is very relevant. How we can go for a very gentle care for the baby in delivery room.
Yes, thank you, sir. So first of all, I will to take this question because this 29 weeks, the baby didn't receive any antenatal steroids. The baby is normal, vaginally delivered, and he is not having any distress. So, but still he has not received steroids and he is a 29 weeker. His lungs are definitely immature, and there is a high chance that he can go into atelectasis, and subsequently, gradually he can develop this respiratory distress syndrome or high oxygen requirement. So what I would like initially to do is that I don't want to intubate him, but to keep him, if resuscitation, even if it's needed, always use a TPs rather than a bag and mask ventilation, because even if you don't know how to use this bag and mask ventilation, TPs will be a better option for us, because it will control PIP and PP to deliver, and also you can control the inspected time. And also, I don't go for this sustained inflation. I'll start with the delivery room CPAP immediately after the birth of the baby. And if you want to shift the baby to NICU, I'll use a TPs to shift the baby to the NICU. And also use of oxygen, we have to be very cautious while using oxygen for these babies. I know many of the centers are not having blenders, but still we can use this indigenous blenders, like mixing up of this air and oxygen, and you can use this 21 to 30% air oxygen blender to resuscitate those babies, and never ever use this 100% oxygen unless you want to start this cardiac compression for these babies, because, as per the protocols. And also it is better to have a pre-ductal oxygen saturation printout, a chart which is taken a printout, laminate it and keep it in your labor room, so that you will be able to attain the target oxygen levels. So these are mainly that my messages I want to convey. The thing is that start with the TPs, even if the resuscitation is needed, always use a TPs, blended oxygen, and start with the delivery room CPAP, and always a target oxygen saturation or the pre-ductal saturation is required.
So I got 3 clear message. The if required, early and continuous, uninterrupted. CPAP required for the babies to be started, which a TPs can give. A ambu bag cannot give CPAP. A ambu bag by PPB it can give, but no CPAP. So CPAP to be, if given, the TPs should be there available in the delivery room. And the second message is very, very clear. The oxygen is a drug. Whenever we want to give drug, it's dose dependent action to be monitored. So when you are giving a dose of drug or the oxygen, it should be graded. It should be blended from 21% to 100%. We cannot give the full dose of some grams or some milligram of dose to anybody like antibiotic. So we are as per the kg we are giving. Like that here, the dose should be available to either incremental or decremental way. We can give the dose, then only it will be right. So the blender should be available. Whenever we're giving a drug like we're giving inotrop, what next do we want to see? How the blood pressure improvement, how the perfusion improvement. Here also, by just giving the oxygen is not the answer. By giving the oxygen, if you're achieving our target, so SpO2, you should taper it. So the chart should be available, as Dr. Murali has clearly advised, a printout chart should be there in delivery room. We achieve the saturation, we should wean as early as possible the oxygen. These 3 practices are very, very important. But one of the practices which missed here, I will request Dr. Giridhar to highlight. In this premature baby's first 1 hour, we all focus goes to respiration, oxygen, PPB. But very, very important one surrounding care is there, which if not addressed, each time we are not addressing that issues, the morbidity of the antenatal steroid advantage, surfactant advance will be nullified, and we will get more disadvantage. Please highlight that care actually.
Very important thing that you have to understand here is temperature maintenance. I think with every...
So just a question we will take.
This child started developing grunt, tachypnea, distress, and grunt. So the confusion of the audience is now on behalf of the audience. So in such case also, empirically, do you want to start CPAP on these children even before this child develops retractions and grunt? Is this the point?
So this question, when it comes to a 34-weeker, 35-weeker babies, more than 32 weeks, possibly we can wait till the symptom comes. But a baby who is less than 32-weeker, antenatal steroid is not covered. That baby chances of RDS is more than 40% later in the ICU. So better to start a prophylactic CPAP in babies who are specific less than 30-weeker, less than 1.5 kilo. But a more than 1.5 kilo, more than 30 weekers, probably has symptoms. The caffeine also goes as per symptoms. The CPAP goes as per symptoms. But prophylactic CPAP, prophylactic caffeine is very, very clear message we want to give. We created a scenario of 29 weeks, which is a real scenario. A 29 weeks baby, they thought 29 weeks baby, 1.1 kilo baby, nothing required. After 2 hours, they saw a deteriorated baby. We don't want to see a deteriorated baby later. So let's prophylactically CPAP start for a 30-weeker, which can protect the baby's lungs later. That's the clear message for less than 30-weeker and less than 32 weeks if less than 1.5 kilo. Better to be prophylactic rather than later rescue with a disease or a RD baby later with the intervention.
So one more thing, that during resuscitation, especially for these babies, we always think about respiration. But another things are the cord management, especially the need for delayed cord clamping. And in this population, it's going to be more than 28 weeks, a 28 to 32 week population, where a lot of times these preterm babies don't have that smooth transition. They are born a bit depressed. They require some amount of resuscitation immediately after birth. At least in these scenarios, other than early cord clamping, even though cutoff is 30 seconds, in between this 30 seconds time, a little bit of cord milking can be advised. But mind you, this is only for babies which are more than 28 weeks. It's going to be less than 28 weeks. Don't advise cord milking. Tell your obstetricians about that. As a neonatologist, temperature. That's a very important thing here. I think maintenance of temperature in this baby is very important. A degree fall in temperature increases a lot of things. The mortality goes up. A severe rate of RDS goes up. Your IVH rates goes up. So these babies don't do well if they come even to the NICU in an inborn baby in a low temperature. So that is the reason I think care should be taken at this point of time to maintain the baby's temperature as close to the 36.5 as possible with whatever means. Your warmer is there. In addition, we know that these babies lose temperature in spite of being under the warmer, getting restrained there. So additional temperature control measures like using polythene wraps, your hats for the babies. At least these are two common things which we do in our scenario. And to remember the delivery room temperature also should be at that 25 to 28 and not the less than 25 at what we generally see in most of the units. So those are the two things that I would like to highlight in addition. And one more question with sir's thing, the prophylactic. So I think instead of using the word prophylactic here, even if you go to the Cochrane review, which actually looked at CPAP in the delivery room, they have given two criteria for that. Using it either prophylactically or as a very early rescue within the first 10 minutes of life, once a babies have been known to have some amount of respiratory distress. And both these scenarios, CPAP has been found to be useful, provided that the control group, we had only oxygen being given like this state. Okay, so if we have a scenario where we could wait a little bit, see how the baby is behaving, and then start CPAP also, that could suffice, but we don't have good control studies for this intervention. I mean, this sort of a comparison.
Absolutely, I agree. All the three components, the continuity of temperature care, it is not only just warming in the delivery room, but continuing the warm chain and continuing during transfer of the baby from the delivery to NICU. So the preserving the temperature, because as we know, all we talked about steroid antenatal steroid slide, what we spoke here, one dose of completion of steroid dose decreases all things 30%, 33% of all these morbidities. 1 degree down the temperature below 36 degree, the increased mortality 18% to 28%. 2 degree down, you can imagine whatever good thing you did, all nullified by this low temperature. So hypothermia should not happen throughout the care, in delivery room, during transfer, and in the NICU. That should be preserved so the all outcome will be better. So then coming to the primary treatment, these RDS babies means we are looking for primary. Till now we managed stabilize 2 primary treatment. We'll speak in next few slides. So 2 primary, what are the 2 primary intervention we are interested in? A small babies, CPAP, prevention of the further RDS by starting early, and if required, starting early surfactant. We know, I'm not wasting some time here by how the surfactant works, how the surfactant helps, but we know in all the RDS preterm babies, surfactant definitely going to help if that is needed. So again, the pathophysiology, we are bypassing it directly. I will go to. We know that any lungs which is easily collapsible, atelectative or low volume lungs, if you put on surfactant, lungs alveoli opens up, and by putting CPAP, the airway distending pressure again recruitment happens better and better. These two basic things we want to achieve, but as per the need. As I told, which is needed for a 24-weeker baby may not need for a 32-weeker baby. For a 32-weeker baby, if we ignore, the 24-weeker baby may suffer if we are not providing the right care. So it is not uniform across the 24 to 34, but we'll see where to use what we learn through the process here. Just to clarify, before coming to the question of surfactant, to clarify how the surfactant management happen in RDS, if the baby is before the symptom, with the pre-ventilation, the brief before the any distress happens, or some cases of a post-ventilation also, if RDS pictures are not the radiologically or clinically, we are starting the surfactant, it is prophylactic. If we are waiting for a baby's symptoms to happen, RDS in any scoring, clinical scoring we are doing, we are assessing by ultrasound, we are assessing by X-ray, we are seeing that there is a clear RDS there of symptom. That time we are giving surfactant probably 15 minutes onwards till 2 years, 2 hours of life. That's early rescue. And beyond 2 hours, in symptomatic babies who are later symptomatic and early symptomatic, we are giving surfactant later. Beyond 2 hours is known as late rescue therapy. So in the total, this whenever this 3 ways we know, I will ask Dr. Giridhar the question directly to him this time. How will choose which is the best mode, which is the best way to give the same question again? 3 different modes we know. Should we give all the small babies the prophylactic early before the symptoms, or should we choose which will require the early rescue? Or some babies, some may argue this babies, if I will settle down with the CPAPs, I will wait. And sometimes if the cost issue, somebody can raise a cost issue or a financial calculation, can say if not required, I'll wait for 2 days or 1 day. I can go for a late rescue. Why the early rescue also? So how will judge which baby and what time exactly to choose the surfactant to be given?
Yeah. So, I mean, thankfully, it's not the earlier era where our steroid coverage was less. Now, our obstetricians are well aware that steroids need to be given for the eligible antenatal mothers. So, luckily, we see around 60 to 70% of these mothers actually having received steroids. So, in this scenario where we have access to very early CPAP and mothers have been steroid covered for that preterm delivery, which is going to happen in that particular period, I think once these babies are on CPAP and there is an escalating respiratory concerns, like babies having increased SAS scores, or the baby's FiO2 requirement is going beyond a particular threshold, like 30% or even 40% if it is going to be a bigger child, those are the children which will be actually eligible for a surfactant replacement therapy. And now the last Cochrane review was also saying this, using the very recent trials which actually incorporate current practice of very early CPAP. Now the benefits of prophylactic surfactant has gone. So now it's going to be only rescue surfactant, but rescue is give it as early as possible. That is where I think we'll have to there. So this is going to be a standard. So a preterm eligible child with RDS supported on CPAP, having escalating oxygen requirements or escalating respiratory distress, X-ray need not be done, blood gas need not be done, go ahead and give surfactant.
A clear message, single liner message. Probably you don't like to give prophylactic surfactant. You want to stabilize with CPAP, fails, you want to go to early rescue, but no delay again.
So one more just little comment is, we have, when people are running outbound units, once you have to transfer the baby over long distances, then there could be a role, especially if you're going to be, baby is going to be an ELBW child, an extreme preterm child, where you need not have to actually, you can give a dose of surfactant and actually bring the baby also, but it is context specific only. I think since you are doing a lot of transports, I think babies who are, even though we want in utero transfers, a lot of times our calls are only for babies who deliver in other places at 25 weeks and 24 weeks also. And these babies at that point of time, when we reach that place, they're on hood oxygen. So we start the baby on, and your transfer is going to take 1 hour, 2 hours. So that could be a role there that for prophylactic surfactant. In spite of the baby being stabilized on, not prophylactic, in spite of the baby getting stabilized on CPAP. But I think it depends on the units. So I would like to do that. So comments should be welcome from other people around here also.
So one thing to clarify, early rescue means CPAP fails you are giving, and some cases when the NNF recommendations age, the 26 weeks and below 26 weeks babies, if the baby is still CPAP, baby is stable, but you are transferring from somewhere, and baby's antenatal steroid is not covered, a early advantage of surfactant can be considered. That's the second recommendation came. So then the third one I'm highlighting, this combination of all the summary, what it says, you do the prophylactic surfactant before the stabilization of CPAP, all the disadvantages are higher. You talk to mortality, talk to BPD, combination of BPD and death, all are higher in the prophylactic group. So we are not going to prophylactic, we are stabilizing. But another question you raised here, transported babies not given surfactant, came to me 6 hours of life, what I'll do? There also on line, the NNF CPG has put a line there, up to 72 hours. If the baby came late, somebody has not treated optimally, came too late, think about giving surfactant if there is a RDS picture is there. Somebody is recommended, actually first 2 hours, not treated, came to us 8 hours of life, 10 hours of life, what to do? So first 72 hours we can think of, but beyond 72 hours, treating with surfactant even is not much useful. That time maybe ventilated, maybe the lung damage started. So that's guideline, one caveat, one line added there, up to 72 hours if required. That's probably we can go late. I was asking that question, the practice questions. So next question, Padmini Priya, Dr. Padmini Priya. If you want to give surfactant now, how will give will come later, but what molecule, what drug you choose? What dose you will choose for a newborn baby like this 1.1 kilo baby?
Usually we will be having the preparations as natural and synthetic preparations of surfactant. We would advise to give only natural surfactants rather than going for the synthetic surfactants. Among the natural surfactants also, we will be preferring the Curosef because the volume of Curosef that should be given will be very small. That can be easily given for extremely tiny babies also when compared to that of a Survanta, which should be given 4 ml per kg, rather than the Curosef, which is only 2.5 ml per kg. So Curosef has that benefit over the surfactant in giving in selecting the type of surfactant that should be administered.
Probably we are not endorsing any brand. I want to clarify here.
But
the Curosurf, even the NNF CPG guidelines says the Curosurf is a little better than Survanta. But caveats here, Curosurf use 200 milligram per kg and Survanta use 100 milligram per kg. How apple can be compared with orange? A 200 milligram per kg comparing with 100 milligram per kg, how much right? We don't know. So we are not endorsing brands, but a bigger baby, large volume required, you can choose a different brand. Extreme small baby, 600 gram to 700 gram baby, small volume can be done. The delivery can be easier. And which methods you are delivering the surfactant, depending on that, you can choose your products. But either way, natural surfactant is effective. That's clear guidelines. So either use Survanta, use Curosurf, or other any brands, alternative brands available to us, natural products, all are going to work. But is the right dose. One may be 5 ml per kg, one may be 2.5 ml per kg, one may be 4 ml per kg. But the right dose, as per recommendation we are going, the effectiveness will be there. The next question comes, after surfactant, you want to give surfactant now. Next question, probably Dr. Giridhar. How we want to deliver? Now when to give, we know. What molecule we want to give, we little confusion. But so which method you want to deliver?
So delivery method, because internationally, because people have gained more expertise with your less invasive or minimally invasive surfactant administration method, where a thin stiff catheter is passed across a baby, the vocal cords of a baby on CPAP. So that is a method that is preferred everywhere. But this method, as you know, it has a lot of brownie points. I think it has been well proven that when compared to other methods of surfactant administration like Insure, it actually helps out in reducing the BPD rates and the composite outcome of death and BPD. Also, the need for ventilating these babies also is less in this method called less invasive surfactant administration. But the problem in India is this method actually takes a lot of training. And our expertise with intubating the baby, visualization, and passing the tube across is one concern here. And a lot of reflex also happens when we actually administer surfactant using this method. The side effects, it could vary depending upon the expertise of the units also. It could go from 5% to 30 to 40%. So I think if your unit has expertise in this particular procedure and you have and requirement of a senior consultant, the person who has had experience of having done this procedures over and over again, we could choose to go with this method. But have a word of caution here. Again, even though this method in the very recent trials which have used this method in extreme preterm infants, like the Optimist A trial or the Cali trial, they have been found to be successful. I think when you are looking at very, very small babies, where I think babies more likely to be intubated right in the delivery room, or coming to the NICU getting intubated for some other reason. So if they are not intubated also, I think intubation surfactant versus Lisa is a query in this population of babies who are extreme preterm, especially the ones which are 26 weeks and less. So
coming to evidence, even the last, this is the current evidence, compiling all the meta-analysis. Majority, total 217 studies are there, combining 9 meta-analysis. Combining all the 9 meta-analysis, the final result they are giving, Insure and Lisa, if you will compare, the Lisa less invasive method without a intubation, the less invasive with a catheter delivery, the surfactant by a catheter, without giving positive pressure ventilation. Insure, what we do, put a tube, tracheal tube, we bag with ambu bag or a key piece. The Lisa method, what Dr. Giridhar highlighted, less invasive, we are not bagging. Baby spontaneously breathing, we are providing CPAP, but giving delivering. That's across all evidences are promoting that Lisa or missed, whatever methods we say. But the point what Dr. Giridhar raised, I want to again highlight it. We don't treat till now the babies by reading books. Whomsoever neonatally sitting here, I don't think reading books, nobody treated the babies. By learning the skill, by understanding babies' pathology, we treated. So clear highlighting point here, if you don't understand, we don't have the training, the expertise, the skill to monitor. You just imagine a surfactant costing 14,000 rupees. You don't have the skill, put in the tracheal and the reflux and gone to esophagus and stomach. Is it okay for the family and the baby? After, if you're given Lisa, put on CPAP, the regurgitation happens, choking happens, and brady desaturation happens, nobody's there to monitor. Is it right for the baby? So if you're doing Lisa, there is a clear, the evidence, all the evidences from the Western world, from the Indian studies also, 3 Indian studies are there in this, whatever 217 studies I told, they're promoting do Lisa. But when we are talking, doing Lisa, we should be careful enough to monitor and should be skill enough to do the procedure right as highlighted. And the cost-wise also, if you're seeing the catheter, if the right catheter, you will use a feeding tube, which is maybe costing 10 rupees or below that. But a right catheter, maybe 1,500 to 1,600 rupees. And how many units for delivering the surfactant? Another 2,000 rupees can add there. So these all things taking into account, you can do Insure, you can do Lisa alternatively. But both the places when you are doing, we should be careful enough that you are trained enough on monitoring the babies further. Because the babies who, small babies, Lisa, they do good. So can I do a bigger babies? Bigger babies, 2.2 kilo baby, a pneumonitis already, but the RDS, bigger baby, required a good large volume of surfactant. We're trying to put a Lisa. That's the trickiest rather than a 700 gram baby. When we did Lisa for last 5 years, we saw 700, 800 gram baby we are doing and putting on NIV or CPAP. That's more stable. A 2.2 kilo baby, 2.3 kilo baby, struggling, fighting with CPAP. Just we will put surfactant. That's might not work. So sometimes we have to, what we have to do? To reasonably, baby's pathology, we have to understand a severe disease in a bigger baby also, better sometimes do Insure, delivering your all the medication to the lungs, maybe right approach. So quickly, another 2 to 3 slides are there. I will go to that. Dr.
Babies, I think the Insure or other methods are probably in the study.
So what the extrapolation we are doing? Extrapolation is if a small babies can do well with Lisa, why not a 2 kilo baby? Why not a 1.8 kilo babies?
Right. Okay.
Because a smaller baby after Lisa, nothing we are giving, just CPAP. And Insure what you're doing, delivering, putting PPV, then putting CPAP. So if there's people extrapolating that, I'm raising a issue.
Yeah.
Direct extrapolation little tricky because maybe a struggling baby and you may require 8 ml of surfactant. 8 ml of surfactant Insure may be a better way to deliver rather than putting a catheter and delivering. So these all things to be considered, not just direct extrapolation of one small baby doing well, one big baby also can do well. And big babies with a PPHN shortly within 4 hours or a lungs pneumonitis, if that baby is troubling us really a troubled baby. So ventilate, Insure, continue rather than just removing the catheter and a struggling baby within 2 hours of life. So that's the message.
Yes.
So it's not smaller or bigger. It is a pathology, how it can be serious one in that particular baby. So after that, I will few quick questions now. I probably have time now out within 2 to 3 minutes. We have to finish it. So I'll say regarding caffeine, what you want to, the practice points, want to learn, and the practice point everybody should learn. What will do, Dr. Suresh?
Sir, as we all
you want to give caffeine, or if you want to give, what's the best time to give caffeine?
Yes, sir. As soon as possible, especially if baby is below 30 weeks, before 2 days is the ideal time, sir. As soon as possible. Prophylactic caffeine has both short-term as well as long-term beneficial effects. It decreases apneic episodes and decreases the need for mechanical ventilation, PDA, And in the long run also, caffeine proven to be it decreases neurological morbidity also, decrease incidence of CP.
So below 30 weeker, the prophylactic, always we are talking about prophylaxis. Above 30 weeker, if symptomatic.
Symptomatic, yes.
So below 30 weeker, if prophylactic, you want to give in delivery room, you want to give immediately after admission into the NICU, you want to wait and give later after stabilization.
After initial stabilization, preferably before 2 days.
So before, if before 2 hours we are giving the best, if you miss the opportunity up to 2 days, we are giving still the advantage preserved.
Yes.
That's the message probably. So quickly, Pragam, we are moving actually. I'm stopping you in between. Sorry for that, but I have to move to the next question. The babies may be different. A 600 grammer baby, 900 grammer baby, at 1 kilo baby. I'm showing 3 pictures. Somebody needs intubation surfactant. Next baby surfactant with CPAP. Third baby only just HFNC baby is stable. A baby 1.2 kilo, 1.25 kilo, maybe HFNC also stable. So babies are different. They require different modalities of respiratory support. But to conclude it, I will ask Dr. Giridhar the question here. If you are having all the facilities with you, you are having training, expertise, the monitoring, the staffs are there, the nursing staff's good, the registrars are there. How to choose is a primary mode and secondary mode, if available, all the machinery to you. When you will choose NIPPB as NIV mode, when you will choose CPAP as a NIV mode. Both are NIV mode, non-invasive ventilation. One is CPAP, only the continuous distending pressure. Other is we are giving a positive inspiratory pressure and providing the CPAP. So which method you will use? And this probably both you can conclude as a primary and secondary.
Okay, so I mean, I'll talk about the primary mode first. When a baby comes to the NI unit, so I'll just tell what I do in the hospital and then give the why I do. I'll let you know about that. What I do is babies 28 weeks and above, these babies will be on CPAP only. And if they fail, if I feel that they're failing CPAP because of some criteria, because of some weak respiratory efforts, or your blood gas is showing that they are having some respiratory acidosis, then I escalate to NIPPV. If the baby is going to be 28 weeks and less, or 1 kilo or less, or the baby is born depressed at birth, but otherwise baby is doing fine, then the baby is on non-invasive, then I prefer to go in for NIV, that is NIPPV, as a primary mode of managing these babies. And as a policy, I don't do, high flow as a primary mode, even though some units actually do that. High flow is a bridging therapy. That is bridge between your NIPPV CPAP to oxygen, low flow oxygen. So that is what I do. I think high flow, we have good studies which says that as a primary mode, it doesn't work when it's not comparable with CPAP. It's inferior to CPAP. People have done some non-inferiority trials with high flow. Has been found to be inferior. Where high flow could actually work in the post-extubation scenarios. But in this is about my primary mode. When it comes to the baby who's planning to get extubated, so all these babies with the same criteria, they're going to be 28 weeks and above. It will again be your CPAP. The only thing is extubation of very small babies. I tend to do it on the give higher pressures. The pressures which I tend to choose are around 6 to 8, rather than the usual 5 or 6 which we choose depending upon what they the time they got extubated. At the time of extubation, what pressures they were on the invasive mode of ventilation. And with the same 3 criteria, they're going to be 28 weeks and less. It's NIPPV. It's going to be more than 28 weeks to 34 weeks. I'd go in for CPAP. And then as a rescue mode, I would choose NIPPV. And high flow is again going to be as a bridging thing when during the transition phase between CPAP, NIPPV to oxygen.
Well said. Actually, guideline is very clear. Depending on the seriousness of the baby disease, we can do. Before closing the session, before we have to close because of time limit, few of the discussion there, I will suggest one thing: the supportive. When we are talking about CPAP surfactant, you have to think about how the supportive monitoring going on, how the temperature care going on, the infection control, the nutrition. These are all relevant in the preterm babies. But along with that, I should say, the baby is not so sick. Try to limit your investigations. And if you're doing investigation, try to be non-invasive. Instead of X-ray, we can do ultrasound lungs. Instead of arterial stub, arterial ABG, we can do a capillary ABG, capillary blood gas. These are the few things you have to take care in the units. And coming to concluding the session, I invite all the panelists one message for these preterm babies, how to optimize the care. One message from all of you, then we will conclude the session. One message from all of you.
My message is stratify your babies. That is, a 800 gram maybe 800 gram weight baby is not equal to 1.5 kg baby or 3 kg baby. So stratify your babies, do your minimum investigations, and minimum handling those babies. And as the heading of our panel discussion today, less is more, and primarily do no harm for these babies.
Thank you.
Antenatal corticosteroids we already discussed. As oxygen is dangerous in a dose dependence manner, caffeine is a time dependent. Like, as soon as possible, like early caffeine will have better outcomes.
The limit oxygen use.
Limit oxygen use, dose dependent. Caffeine is a time early we have to.
Perfect.
So my message for the audience is, I think, I mean, our respiratory care is still a work under progress, and we are still, I mean, even though that we know that evidence is very certain for certain things like Lisa, we are still learning the art. So learning the art, it's a learning curve. So ensure that your staff is getting well trained. Keep learning, relearning, and unlearn certain things that are actually not to be done in the babies. That is very important. And next, concentrate on the transport also, and like maintaining the temperature during transport, the respiratory care they support, because a lot of units maybe still deliver outbound and they're getting transferred to level 3 NICUs. So this is one area that we should concentrate on.
Well said.
As everyone was clearly telling about the importance and take home message, sir, in a resource limited settings such as ours, where we think of importance of giving the antenatal steroids rather than going for the CPAP and everything, where it will not be possible in each and every institute. So in my opinion, every preterm is not the same in the same institute or in the different institute. Even my preterm baby in my institute delivered, it will be handled differently in the other institute. So according to your circumstances, according to your situations, you treat and manage that case, whatever feasible it is there. So in our setup, prevention will be the better thing, that is giving the antenatal steroids so that reducing the respiratory morbidity. And sir was clearly telling about the early caffeine therapy, which is also one of the simplest measure, not going for the CPAP or invasive ventilations. So I think, in my opinion, that.
So concluding the session with one golden bullet of antenatal steroid and silver bullets of neonatology caffeine, and with less treatment for the babies, probably we'll conclude the session with this. I think less is more is apt in the whole neonatology, not in the preterm babies. Whenever we think any intervention, we learn aggressive management first. Over years, our maturity taught us how to be gentle, how to be less, which will be effective to the baby. With that, thank you all for the patient hearing, and thank you, my panelists, for giving the right input. Thank you.
So thank you, sir, for the wonderful session. So now we will be going on to NNF Digi launch and also say all about sepsis launch. So I welcome AP State Secretary NNF, Dr. Ramprasad sir, to carry on.
Thank you, Rajesh. So, very good morning, good afternoon, all. You have been very patient throughout this since morning. So, actually, what purpose we have meted, now we are going to do that one. That is launching of DigiNNF. And very happy that under the footsteps of Lord Venkateshwara, we are going to launch under the dynamic and visionary leadership of Dr. VC Manoj, who is taking this NNF India to a newer mode of DigiNNF. Sir, Dr. VC Manoj, sir, please come on to the dais. A dynamic visionary leader who has started as DigiNNF and many more laurels to come under his name. Sir is the NNF India President. Now I request NNF, Central NNF EB, Dr. Vishnu Mohan. Dr. Vishnu? Yes, yes. An neurologist from Kerala. Thank you, Dr. Vishnu. Now I request teacher of teachers, guru of all gurus, very special moment for all of us. Dr. R. Sir has been teacher for all of us, and whatever basics we have learned and whatever encouragement he does to all the students, we all, sir. Now I request our principal SVMC, Dr. Chandrasekhar sir, and to ask.
Now I request our HOD SVMC, Dr. Manohar sir, to come onto the stage. Now I welcome Dr. Ramprasad sir, Secretary NNF AP State. Please come to the stage. I now welcome Dr. K. sir, President NNF, to please come on to the stage. I now welcome Dr. Satish Billa sir, Secretary IAP Tirupati State, Tirupati. So now I welcome Dr. Sridhar sir from CMC Vellore, Chairperson for All About Sepsis Committee. Now I welcome Dr. Rajgopal sir. Sir is a Chairperson for DigiNNF. So now I welcome Dr. Manoj sir to come for the presidential address.
Respected teachers, seniors, and my dear friends. I bring warm greetings from National Neonatology Forum India to this holy township on the foothills of Lord Venkateshwara. It is actually a proud privilege and a true moment of honor for me to speak to you as President of National Neonatology Forum, a very dedicated group of comparatively not so big, 10,000, 11,000 members spanning across the country who all believe in the philosophy of taking care of the lives at the beginning and the most crucial period of their life. NNF is peculiar in that this is one of the organizations primarily of doctors, but then it doesn't have only doctors. It is or anybody who believes in the philosophy of the right kind of newborn care is free to join it. We have a lot of very learned nursing members also in NNF and various other healthcare providers also. We all, so NNF is not a branch, neonatology is not a specialty, it's a mission. Neonatology is all about a mission to save lives, shape lives, and actually do one of the most noble service that you can do as a healthcare provider. At the most crucial period of life when the baby transforms itself from the fetus to the newborn and face all the vulnerabilities, We are the ones who actually hold their hands, especially the more vulnerable ones, and then transform them or help in the transformation into what is going to be a bright future for them. Today, I have great pleasure and honor to launch our premier action plan for the year and hopefully in the coming years, a mother platform that is going to increase the visibility of all of us. DigiNNF. DigiNNF is envisaged as a platform for various other action plans as well. And this includes primarily 3 categories or 4 categories of activities that NNF strives to do and tries to improve upon the performance every year. Of course, the academic activities and the added element we have put in the DigiNNF is the social platform. Think of DigiNNF as something like a Facebook and LinkedIn combined one for the neonatologists, where we have provided, or rather we hope to provide visibility and connectivity to reach the unreached everywhere. Everyone will be able to reach each other, having their own space where they can broadcast their activities, and at the same time, they will be able to connect. This will also help us in reaching the unreached, the theme of our activities for this year. With this theme, we envisage a lot of activities. One of them we had just launched 2 days ago. Some of you might be aware. It's a social outreach program where we hold hands and give guidance to the practicing pediatricians and neonatologists when confronted with a rare disease, be it an inborn error of metabolism or a genetic disorder, and help them in guiding how to go about, very streamlined. But the better part of it is we provide financial assistance to any neonate born anywhere in the country if they are suspected to be having a rare disorder. That's why we had to, our original plan was to start launching our action plans from this holy city, but then that was launched 2 days ago on the World Rare Disease Day Eve on 27th. So that is that project is called NNF Help. Today I have again great honor to release another action plan also along with DigiNNF that is all about sepsis. This is something that we do where we combine the academic science, evidence-based guidelines, and the practicality, everything all in one. So let me start with introducing 3 chairmen of the 3 committees all about sepsis. When we thought about this, I had no other name in my mind. Professor Sridhar Sandhanam from CMC Vellore. For our DigiNNF, the mother platform, we had a large team headed by Dr. Rajagopalan, Dr. Giridhar, Dr. Srinivas Murthy, Dr. Venkat Kallam. The big list of people are there. So they are all looking after. This needs larger team because we need to include everyone on this. There is a special page on that called Neo Expert, which is the academic and social clubbed into one, or rather it is something like you ask any problem that you have in managing a baby, the NNF panel of experts will reply to you within 24 hours. And this will be very useful when we are stuck with a case or when you're stuck with an X-ray, when you're stuck with the ECG, what to do. you post it there. This is a idea that has been added on to DigiNNF. It's called New Expert. The page in the DigiNNF is called New Expert. It will be headed by Dr. Dinesh Chirla and this great team of lot of doctors who will be monitoring and mentoring this panel. So now we have various other pages as well in DigiNNF. I told you about two now, peer networking and New Expert. We have various other pages. There is a page for states to announce their activities so that people everywhere, once they log in, they can see what is happening to this state. You go to that page, only the office bearers of that state will have permission to upload the activities there. They upload there and then you can see. So our idea is to bring everyone together, inclusivity, but this plan will not succeed until we all involve ourselves. So my humble request to all of you today, we are just launching DigiNNF and all about sepsis today. So as far as DigiNNF is concerned, our humble request is in the next 2 days, all of you, if you log in after 2 days, I would say, because that is a launch. After that, initially there will be, we expect some teething problem because it's a massive project. So after 2 days, log in with your email ID. Just type diginnf.com. You can download and keep that web-based app on your phone, or you can every time type, go on to the page. So once you are asked to go to DigiNNF, enter your email ID that is there with your membership number in the NNF office. There is a problem, you need to contact NNF office because there are two sides of DigiNNF. One is a social platform. I'll talk about that in a minute. And the other one is members area. So I'm talking all these facilities, whatever I said, are there in the members area. So you go to DigiNNF, type a email ID, you will get a password in your email, log in from there, and the page is yours. We have envisaged DigiNNF as also a platform for increasing the visibility of NNF everywhere, reaching the unreached again, reaching to the parents who are needy. So we have another area in DigiNNF which will come, which will have its full shape in the next couple of weeks, called parental empowerment, where that's an open space. Initially, there will be FAQs, and then subsequently there will be, we hope to achieve the interactive platform as well there, where parents ask. This is again another massive project which has been envisaged. I must admit, this is not my brainchild. This is actually the brainchild of NNF President 2023, Dr. Praveen Kumar. He had envisaged us in a different way. So I had actually modified it to this. So Sir Praveen Kumar sir will be the advisor for this, and Dr. Rishikesh Thackeray will be the chairman of that committee, and that committee is expected to get things in shape soon so that we will be, parents will have an access. That's a very more, I would say more responsible area where like NNF phase is involved. So, but then we need to have in there are going to be challenges. I envisage challenge at every point. Suppose somebody is stuck with a case, you go to New Expert, you ask your question. If you do not give correct data, the advice that you get will be different. So this disclaimer will be there at all points. If you are able to, this is not a ENICU. This is something else, but of a similar concept. So here you actually give the correct data. With the data, what you need to do, New Expert will advise you. So that this is something, there's a service to the members. So we should make use of it in a right direction. There are various other plans. I'm not elaborating already. The session is running a bit late. So I would cut short my talk with a simple message to all of you. Please do log into DigiNNF after 2-3 days. If you have any problem, please contact You can either email to connect@digiNNF.com or you can call the NNF office. They will direct you. Otherwise, I do not want the chairman, the coordinator, others to be chairman and coordinator are here. Raj and Giridhar are here, but the others also, you can personally contact them also whenever they are free. So that is one request I have. Another course I wanted to say a few words before I stop is all about sepsis. We all deal with sepsis. Unfortunately, this is an area which we don't really understand. Any baby coming with respiratory distress, first drug that you give is the worst antibiotic you can give to a baby, taxin, amikacin. That is how we have practiced neonatology. We should aim to have a antibiotic-free NICU. Very utopian concept. Any baby coming with, if you know that baby is having RDS, it doesn't require antibiotics, it requires CPAP, just as now you heard. Or rather, alveolar recruitment, surfactant, or probably if you have not done your homework by giving antenatal steroids and things like that. But our first drug is always antibiotic. We feel safe. When there are studies saying that prolonged antibiotic use, mortality increases, not even morbidity. You kill babies by giving antibiotics. You destroy their life forever by changing their microbiotic flora. So what are we doing? We should know the right guidelines. We need a clear idea, prevention, how to use antibiotics. All these will be covered in this course. Course will be launched in April. So the details will be available in DigiNNF once it's launched. And you can contact Dr. Sridhar Sandhanam and his team. He is actually looking after this project. And all of you know Sridhar. He is a no-nonsense man. And the way, I mean, he conducts, I am sure that all of you who register for that course will be immensely benefited. There are other things coming up depending on how much we can do, but then this is going to be, and I am fortunate to have two successors who have promised me they will continue this program. 2026 President Dr. Lalan Bharati and 27 President Dr. Somashekar Nimbalkar have promised me they will continue all these, at least for 3 years, because all the action plans have the life span of the tenure of the president, unfortunately. So at least, except programs like the one launched by Dr. Ranjan Pajawar, Noel, nobody will touch it now because it has got its status. So let us try to have status. I mean, the programs, let them outlive. I do not want my name or any of our team's name to be remembered, but I want the programs to do actually good. And the program should speak for themselves. So that's why we believe in distributive power. I'm not going to interfere in any of these actually, because we have legends looking after each program. But if they're stuck, then it's my responsibility. So I am sorry for taking so much of time. I invite all of you to join for more and more activities by National Neonatology Forum. Let us all work for the betterment of newborn babies of our country and take NNF to greater heights. Thank you.
Thank you, Manoj sir. And as a mark of launching of this DigiNNF and all about sepsis, I request all the dignitaries and us to come for lamp lightning also. So we'll have this enlightening of wisdom of lamp. I request Kiriti sir to have one devotional song.
आरार्तिक्यं कर्पूरगौरं करुणावतारं संसारसारं भुजगेन्द्रहारं सदा वसन्तं हृदयारविन्दे भवं भवानी सहितं नमामि आरार्तिक्यं समर्पयामि श्रीगुरुचरणकमलेभ्यो नमः पुष्पाञ्जलि गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरुः साक्षात् परं ब्रह्म तस्मै श्रीगुरवे नमः अखण्डमण्डलाकारं व्याप्तं येन चराचरं तत्पदं दर्शितं येन तस्मै श्रीगुरवे नमः श्रीब्रह्मानन्दं परमसुखदं केवलं ज्ञानमूर्तिं विश्वातीतं गगनसदृशं तत्त्वमस्यादिलक्ष्यम् एकं नित्यं विमलमचलं सर्वधी साक्षिभूतं भावातीतं त्रिगुणसहितं सद्गुरुं तं नमामि अज्ञानतिमिरान्धस्य ज्ञानाञ्जनशलाकया चक्षुरुन्मीलितं येन तस्मै श्रीगुरवे नमः पुष्पाञ्जलिं समर्पयामि श्री गुरुचरणकमलेभ्यो नमः जय गुरुदेव
Dr. Manoj has been doing wonderful service for the past 40 years. Wonderful service, and I wish it should design and do more and more programs so that we will be able to. So I saved so many babies, especially the unreached babies are there still in our country, in the remote areas, and we have to take this to the community. Thank you. Thank you very much for all my students. I'm very much proud of Venkata Suresh. Just I could not take it because I became old, you know. He's a DNB from Mehta. Venkata Suresh? Venkata Suresh. So he did his DNB. Kada? So DNB pediatrics through me, and then went to Kana. So I could see so many of my students doing wonderfully well. Thank you very much.
So it's now time to honor our dignitaries. So first of all, I welcome Dr. Manoj sir and accept our honors. So, sir is being felicitated by our Armugam sir and our principal Dr. Chandrasekharan sir. And I request all the faculty and the dignitaries to be on stage, please. All the faculty be on the stage.